Okay. Good morning, everybody. Hope that you're able to hear us and see all of our slides. I'm Dr. Traci Downs-Bouchard, for those who don't know me, from Nationwide Children's Hospital and The Ohio State University in Columbus, Ohio. And I'm one of the pediatricians here, as well as in charge of our global health track for our pediatric residents. This is my second year working with the Go High Summer Institute. And we're so pleased this morning to start some of our pediatric and adult lectures. Starting off this afternoon, we have Dr. Sutter from The Ohio State University. He's one of our cardiologists. He does both adult and children, and he's going to be speaking to us this morning on rheumatic heart disease. I'll let you take it over, Dr. Sutter.
All right, thank you. And I may ask you guys some questions throughout. If you can put, answers in chat box, or is probably the easiest place if you can, do that, or even an answered question. So, because I manage rheumatic heart disease on my end at times, but oftentimes I may not be seeing as much rheumatic heart disease as you guys are, and my perspective as a cardiologist may be a little bit different too, compared to what you guys are seeing as pediatrics residents. So I was trained in both internal medicine and pediatrics, and now practice mostly adult cardiology, but was kind of trained in both. So the main goals of this today are going to be understanding the epidemiology of rheumatic heart disease, stages in the prevention of rheumatic heart disease, and then diagnostics and management really across the whole lifespan. So the most recent patient I saw with rheumatic heart disease actually was just a couple weeks ago. And then this will really illustrate the point of it being across the whole lifespan. So it was actually a 65-year-old man with a history of rheumatic heart disease who didn't really develop significant symptoms until his 40s. And he got a mechanical mitral valve at that time at age 52, as well as a coronary artery bypass graft at the same time of surgery. Since that time, he's developed pretty mild heart failure with reduced ejection fraction, atrial fibrillation, for which he's had an ablation, bradycardia for a pacemaker, and then several other diseases of more of the acquired adult diseases we think about: hyperlipidemia, hyperthyroidism, and obstructive sleep apnea. He really came into town with pretty minimal complaints. He was actually a speechwriter for a local judge and former kind of radio host. Very interesting guy. So thinking about his case and kind of when this ended up, when rheumatic heart disease really mattered as much for him. So it was more of an insidious onset throughout his youth. So he didn't even, he remembered he had rheumatic fever, I believe, somewhere between the ages of 5 and 10. And then he didn't develop symptomatic rheumatic mitral stenosis until his 40s and 50s. And then developed several complications of this further down the line. So I think when we think about rheumatic heart disease, thinking about how it impacts people across the entire lifespan, and then how you as pediatricians and future pediatricians are probably some of the most important people involved in the prevention of this disease. So in pediatrics, some of your biggest role would be diagnosis of rheumatic fever, and actually even beyond just the clinician aspect, public health prevention is one of the most important things. As we'll see, there's really large disparities across rheumatic heart disease across the world. And also from pediatrics, what we'd call secondary prevention, or once people have already had rheumatic fever or a group A strep infection, trying to find ways to both treat that group A strep and then prevent recurrences for people who have already developed rheumatic fever, rheumatic heart disease, or the carditis along with that. And then from the internal medicine standpoint, I would consider it more tertiary prevention. So although this is typically a disease that impacts and affects youths and then building complications over decades, internal medicines or internists oftentimes are the ones managing the long-term sequelae or consequences. Um, so just kind of to reiterate this, thinking about primary prevention or primordial prevention. So a lot of what we think about when we think about this really, really early prevention or public health measures, such as overcrowding and dense living situation and people who are often living in poverty, but as well as having kind of regular health care through the time that people are growing up to, and having access to antibiotics if people acquire group A strep. How to treat group A strep pharyngitis, so with penicillin, cephalosporins, or macrolides most commonly, and then the secondary prevention. So we know that patients who have rheumatic fever, who get and who develop kind of the heart complications, even early stages, if they're continuing to get additional episodes of rheumatic fever, that sets them up for more severe and more problematic long-term heart problems. And then finally, as I'd mentioned, more on the internist end, but I think very important when you're thinking about people with disease. When I've seen patients here in the United States or when I've traveled abroad and seen patients, I typically didn't see, when I'd see heart disease on pediatric wards, it was oftentimes congenital heart disease. Most of the rheumatic heart disease I'd see would still be people in their 30s and 40s. So we'll talk a little bit more about the epidemiology of rheumatic heart disease. It affects 40 million people per year and over 300,000 deaths per year. And you can see this map on the right really shows countries that are green really have very low rates of rheumatic heart disease, and then more of the red countries and the orange countries are where it's more endemic, where they're seeing it, people are seeing it more frequently. And as I go through the rest of the slide, this is my question for you: is how often are you guys seeing this on the on your pediatric wards? How often both are you seeing rheumatic heart disease, but how often are you seeing rheumatic fever as well? The prevalence can be as low as 3 in 100,000 people. So even non-endemic countries, we still do see rheumatic heart disease, and probably ends up getting clustered more toward me as a cardiologist in the United States, to over 1,000 people cases per 100,000. So over 1 in 100 people in endemic countries. So more of the orange or the red countries. And then rheumatic heart disease is the cause of heart failure in up to 20% of people in endemic countries. It's considered often a disease of poverty and overcrowding. And then it interestingly receives the least funding relative to disease burden for any tropical diseases. So even though it's a disease of disparities that we can see across the world, it is probably even more of a desperate disease because the funding and attention toward it is pretty minimal. So are you guys seeing rheumatic heart disease commonly on your pediatric wards? And if people don't have access to mics, that's okay. You can always use the chat box too. It's helpful for me to get an understanding of kind of what pathology you guys are seeing.
Yes, they
Okay,
do. It's been in the chat box.
sounds good.
Yeah, a
Um,
lot of it, they said.
yeah, a lot. Okay, very good. Um, and then I'll be able to ask you guys some more questions then about what kind of treatments you guys have offer, what's on formulary for you guys. So um, this is also looking at kind of the distribution of participants by age and gender. So um, this was in kind of for a bunch of different low and middle income countries, looking at over 3,000 children and adults with rheumatic heart disease. And so most frequently you start to see a peak here more in the 11 to 15 range, that you're seeing more increased cases. And then that's really carrying across mostly to about the age of 40. So often a disease of, late childhood, adolescence to young adults, young adults, working age people, uh, and then following up patients with rheumatic heart disease too. So unfortunately, a lot of patients come in. There's both a high mortality burden, up to 20%, a decent chance up to about 10% of developing congestive heart failure. And then, unfortunately, a lot of patients present very late in the course, with 85% of people coming in decompensated. So this is showing even patients with rheumatic heart disease at about 2.5 years. So the percent survival is only about 80% at 2.5 years. So really about 20% mortality. So a really high burden of disease. In terms of the pathophysiology, this may be a review for most of you guys, especially since you're the ones probably frequently seeing rheumatic fever and definitely group A strep infections. But important to note that impetigo can also result in rheumatic heart disease and rheumatic fever. So only a few percentage of people develop rheumatic fever or acute rheumatic fever a few weeks after having an episode of pharyngitis. And then only 30% or so of those patients develop rheumatic heart disease at a year, but actually a pretty large amount of people develop it over 10 years. So really trying to both prevent that episode of acute rheumatic fever and then trying to prevent recurrent episodes. And a lot of the people that do develop rheumatic heart disease do develop pretty significant symptoms, even if it sometimes takes many years, takes 10 years to get there. So it can vary from mitral stenosis alone, which is probably the most characteristic, aortic insufficiency, mixed mitral valve disease is common as well. And really only 20 to 25% of people remain asymptomatic, either regress or progress. So acute rheumatic fever, you guys, I am sure see this more than I am at this point. Are you seeing acute? Here's kind of a question for the chat, if you can help me out. Are you guys seeing acute rheumatic fever more frequently in your clinic or on the wards while you're in the hospital? Um, so, trying to make this diagnosis using the Jones criteria. I like this picture down to the bottom left of the screen. It helps me remember the bone manifestations of polyarthritis, carditis, either clinical or subclinical manifestations, the subcutaneous nodules on the N, the E showing erythema marginatum, and then finally the S for chorea. So I probably saw this pretty occasionally when I was in my pediatrics rotations on inpatient and residency training. But trying to put all these criteria together with two major criteria, or one major and two minor criteria, as are kind of listed out here. So really thinking about these people with either carditis symptoms, cardiac related symptoms, and polyarthritis were the ones I remembered most, and then looking for, because those were usually what people would present with. I think I very rarely or maybe once saw somebody with true chorea with acute rheumatic fever. Thinking about the pathophysiology, there's two proposed mechanisms. One is called molecular mimicry theory, where the infecting organism is antigenically similar to the M protein to the host tissues on the mitral valve, which leads to more of an autoimmune response against collagen in the mitral valve. The other theory is the neoantigen theory. So after infection, group A strep enters the basement membrane in the pharynx or the skin, and then a peptide motif on that group A strep, M protein, binds to collagen, making it immunogenic, which then kind of leads to autoantibodies. I think this is a little bit of kind of more nuance, but really it's thought of almost as an autoimmune type mechanism, almost on both ends. And it's just how the antibody comes about, if it's truly mimicking or if there's a new antibody made, essentially. So getting into more of what I deal with on a very regular basis is the mitral valve as a cardiologist. So we see a normal mitral valve with the large anterior leaflet making up kind of a half moon, and then around it, the posterior leaflet, as well as different scallops that are numbered there. And then the mitral valve, I think, is the most interesting valve because it's got such a complicated structure underneath it too. So it has all of these chordae and kind of tethering mechanisms that attach it to papillary muscles in the left ventricle to try to really regulate that stroke volume that's coming every minute, trying to keep blood flowing forward. So what happens in mitral stenosis or rheumatic mitral stenosis most specifically? So there's commissural fusion, as you can see, the front or that anterior leaflet of the mitral valve, and then the posterior leaflet is on the bottom there. As mitral stenosis progresses, there's commissural fusion and annular constriction, as well as fibrosis and restriction of the subvalvular structures. And I saw a comment about the slides at the end. I'm happy to share slides too. And this is kind of more of from the pathology or the surgical standpoint. I think especially the pictures on the right really show all of this thickening, fibrosis, and constriction of those mitral valve structures. So you can see once again in the picture labeled A there that the anterior leaflet is on the top, posterior leaflet's on the back, but this has really tightened and tethered this valve, both the actual leaflets, but then also the subvalvular structures. And then comparing that to something I see probably more commonly than rheumatic mitral stenosis would be calcific or degenerative mitral stenosis. So, and these are patients that wouldn't be seen in pediatrics, but are important when you're trying to distinguish this on an echo from the cardiologist standpoint, that there's a lot of calcium and buildup at the bases of the valve and restricted leaflet motion, but the tips remain free. And thinking about presenting symptoms in exams. So I would want you guys to, think about the last time that you had seen a patient with new mitral stenosis, new rheumatic mitral stenosis, trying to think about all of the different features that you're trying to pick up. Some of them are pretty common ones. Some of them are kind of some of the more difficult features to pick up. I would say that having a diastolic rumbling murmur in the opening step are the most common. They're the ones that you would see on a board test or on in-service exam testing. And then frequently a holosystolic murmur or in the pumping phase of the heart is seen too. And that's just because there's a lot of mixed mitral disease pathology in this. Frequently, systolic murmurs are louder when they're affecting the mitral valve too, because they're from a higher pressure to a lower pressure chamber. Secondary signs are often from pulmonary hypertension and congestion, such as a right ventricular lift, an elevated jugular venous pressure, crackles and wheezes, or a loud P2, which would be a sign of pulmonary hypertension. And then symptoms you'd be looking for are shortness of breath, dyspnea on exertion, edema, liver congestion, pulmonary edema, and then very frequently atrial fibrillation and stroke, even in younger patients. So I'd say that your physical exam is really important in these patients too, especially if you're not an echo reader regularly like a cardiologist, because the information that you're getting from exam in terms of the murmurs really should be directing a good bit of your care. And I've seen echoes that were discordant with the physical exam and had to repeat the echocardiogram, or different people had to repeat it because the findings really were consistent with mitral stenosis and aortic stenosis from rheumatic disease. Um, so as I mentioned before, patients may be asymptomatic or only mild symptoms for long periods of time, but really frequently patients are seen really late in the course and often decompensated. Because this develops really slowly over very many years, the patients kind of almost have time to adapt or self-limit themselves. And then oftentimes the clinical decompensation seen in situations where the left atrial pressure increases, which would result in pulmonary edema. In these situations would be atrial fibrillation, especially when the heart's going fast. There's less time for it to fill, and more blood would congest in the lungs in the right side of the heart. Endocarditis, as we saw in those pathology pictures, there's a lot of kind of buildup, fibrosis. There's a lot of structures that, um, whenever the heart valves have scar and irregularities, those are places that endocarditis can jump onto. And then finally, in pregnancy, where the total volume of the body's increasing, cardiac output's increasing to keep up with the fetal needs. So in terms of looking at EKG, probably the biggest sign that would be on a testing or come up would be what's called P mitrale, which is the left atrial enlargement that the arrows point to in lead 2 and then in lead V1 here. So in lead 2, you can see that there's a bifid or a notched um, P wave. And then in lead V1, you can see that there's that negative deflection at the end of the P wave. Those would both be indicative of left atrial enlargement. And probably one of the most frequent things that you would need to worry about would be patients who are disproportionately young, in their teens, 20s, 30s, who are developing atrial fibrillation. On chest x-ray, we can get clues for rheumatic mitral stenosis too, such as the left mainstem bronchus that's pointed out with the blue arrow, that's kind of raised up above the left atrium. These are really mostly features of the left atrium displacing other structures in the chest. You can see the red arrows pointing to the left atrial appendage. So there's kind of an abnormal, looking or straightening of the left border of the heart. And then with the black and white arrows, you can see that there's almost a double contour is what this sign is called. So you can see the black arrows pointing to the border of the left atrium, and the white arrows pointing to the border of the right atrium. Usually you can't pick those out quite as well. So echo, as a cardiologist, this is has very, very unique signs beyond just the clinical signs that we're picking up and the epidemiological signs. So you can see this is called a parasternal long axis view. Structures are labeled right ventricle RV, left ventricle LV, aorta AO, and left atrium LA. And then you can see the arrows pointing to the mitral valve. The image on the bottom is a normal heart with the same in the same view. And you can see the mitral valve is noted by the AML, anterior mitral leaflet, and PML, posterior mitral leaflet. So it's a really characteristic pattern of what's called diastolic doming. So when the heart's left ventricle is filling, because that leaflet's tethered, it's not opening well. So it domes out what we call a hockey stick. I would imagine that you guys probably don't play hockey sticks. Do you guys know what the sport hockey is? I'm not sure if it's too famous throughout the rest of the world, but up here where we have cold winters, it's a pretty popular sport. But you see that there's kind of a sharp bend in the anterior leaflet of the mitral valve, and then a really small opening. And you can get some very, very large left atria. So this is from a different view called a three-chamber view. And you can see kind of on the right, toward the bottom of the screen, is the, I can use a laser pointer here, is the left atrium. You can see that's a really large structure. So that's the kind of the filling chamber of the left side of the heart, left ventricle, the pumping chamber of the heart. And then you can see the anterior leaflet of the mitral valve here is doming out on every diastole or every filling cycle. And there's just a kind of a tight hole, that allows blood to enter the left ventricle. So that's really characteristic. And then finally, this is a different echocardiographic view called parasternal short axis view. So the right ventricle is noted up at the top of the screen. The picture on the bottom of the screen is a normal mitral valve. So it's called, the kind of mnemonic is called a fish mouth. So this tightening, this really significant thickening, as you can see this orifice or opening that I'm tracing on the bottom. These are nice thin leaflet tips on the bottom, whereas they're really thickened. The orifice is small to go from the left atrium to the left ventricle. And this is a little bit in the weeds of cardiology. I'm going to distill this down to saying that we use something called M mode, or it's essentially looking at motion in a straight line. And so you have a flattened E to F slope. So what does an E to F slope mean? So it's essentially the diastolic phase. It's the passive filling portion of the diastolic phase. So that portion of the cardiac cycle really slows because that orifice area is really small. When that orifice area of the mitral valve is really small, it takes a long time to fill. So just knowing that there's more characteristic signs. On echo, we also estimate this with measures that help us tell the pressure or allow us to indirectly assess how big the valve area is. And under 1.5 centimeters is what we would consider severe. And most of these measures, again, are based on that slow filling time in early diastole. So it's a hallmark of it. And this is a little bit of the math regarding that. I'll skip through that, but I would just once again highlight that this is mostly based on finding pressure differences between the left atrium and the left ventricle, and then also based on that slow time to filling. So more than the mitral valve can be affected. As mentioned earlier, 20% have aortic and mitral valve disease, and 40% can have mixed stenosis and regurgitation. And then 4% or 1 in 25 develop endocarditis. These would probably be patients you would see pretty acutely in the hospital setting as well. Which scenarios really bring out or worsen symptomatic mitral rheumatic stenosis? So atrial fibrillation. There's a really hugely increased risk of stroke in patients with mitral stenosis and atrial fibrillation. They have a 30% kind of lifetime risk. This was always a confusing topic that I felt came up in training, was what is valvular AFib, what is not valvular AFib? And I would think that this really fits with what's called valvular AFib, and these patients should be treated with warfarin. And one of the, as I said, rheumatic heart disease, unfortunately underfunded, under kind of recognized, under included in terms of tropical diseases. One of the biggest trials in the last few years was one called Invictus, which showed that there were lower cardiac events and mortality treating people with warfarin versus some of these newer agents called DOACs, such as rivaroxaban. So warfarin really should be the standard of treatment for patients. Pulmonary hypertension, if it complicates mitral stenosis, this would be considered kind of the class 2 pulmonary hypertension, or from heart failure usually. So there's a poor prognosis overall, with the median survival only 2.5 years. The treatment is still to fix the valve. And just noting that these patients have a higher surgical risk. Additionally, pregnancy can complicate mitral stenosis, increasing the circulatory volume to try to perfuse the fetus, increasing the heart rate, these can both lead to decompensation. Increasing the heart rate comes back to that point I was making about the echocardiographic information that you're receiving on mitral stenosis. So if the heart rate goes faster, the diastolic time decreases. So the heart actually has less time to fill, and the heart really needs that time to fill in mitral stenosis. If the heart doesn't have that time to fill, then blood will congest in the lungs, the right side of the heart, and the body. So symptoms start when the maternal blood volume really starts increasing around 24 weeks. So intervention is really risky. In mitral stenosis, it's still better to do percutaneous mitral valve balloon commissurotomy. And the surgical mortality risk is high, 9% maternal mortality and 30 to 40% fetal mortality if people were to have open heart surgery. Treating the heart rate's crucial. So although most of beta blockers are considered a class C in pregnancy, they're mostly considered safe and necessary to treat conditions such as mitral stenosis, especially if AFib's involved. So heart rate control with beta blockers like metoprolol, notatenolol, and then diuretics to help decongest the lungs, limit pulmonary hypertension and pulmonary congestion. So anticoagulation is probably the most nuanced point in pregnancy too. So you would treat patients with either warfarin or low molecular weight heparin. They both have their risks. They both need to be considered and flipped around at times based on patient individual needs. So the warfarin risk is dose dependent. That causes fetal defects. So if people are on over 5 milligrams of warfarin a day, it's quite high. If less than that, it's not very high. The risk of warfarin causing embryo problems is highest in the first trimester, which may be when women don't even know that they're pregnant sometimes. And low molecular weight overall, though, is better for the fetus, doesn't cause the issues with embryopathy, but it's probably inferior for the mother. So for delivery, usually a week prior, people will switch from warfarin to low molecular weight heparin or unfiltrated or just standard heparin, and then switch over to normal heparin about a day and a half prior. And this is all to limit bleeding, as warfarin takes several days to increase. Warfarin also takes several days to decrease, again, to normal levels and not cause the increased risk of bleeding. So I think I'm about 35 minutes. I'll try to wrap up through the treatment, and then can take times for questions or interaction with you guys if you have things that you want to learn about. Now, there's plenty of things I'd love to learn about how you guys are treating mitral rheumatic heart disease, especially rheumatic mitral stenosis. So thinking about how do we treat this, or what are the kind of the goals and the major treatment methods beyond just diuretics and beta blockers to slow the heart rate. So probably the most common and the kind of number one goal, if it's good or feasible, would be percutaneous mitral valve commissurotomy. It has less risks overall. It has better access than mitral valve surgery too, but sometimes it's technically not feasible. I guess I'll take a quick break though and ask the group, do you guys have access to percutaneous mitral valve commissurotomy, either at your children's hospital or adult hospital, and mitral valve surgeons? I did know some cardiologists trained in Ethiopia that had experience performing this or working with this in cath labs, but they were mostly adult cardiologists. And you guys can tell me in the chat box if you guys have seen or been involved in or referred patients for the percutaneous mitral valve commissurotomy. Okay. Okay.
Looks like a few no's.
A few no's. Okay. Well, I guess my question, what city are you guys primarily in or working in? I knew that I know that there were some cardiologists in Addis who had done the procedure, did it pretty regularly, and then people I've worked with in Kigali, Rwanda, were involved. This is actually one of the common procedures that they're performing in cardiac cath labs. Okay. City called. Okay. Thank you guys for participating and chiming in. Um, um, and then I would say that still, I guess the second half of that question is, do you guys have uh, cardiac surgeons that come either through short or long-term mission work or permanent cardiac surgeons on the ground that you work with, or are patients being sent out of country at times? Okay. I've got a no for that one too. I'll still go through a bit of this. I won't go into too much of the details, but I would imagine that that makes this a really challenging disease for you guys as pediatricians to be able to treat and to take care of these patients, and would be focusing more on the medical management. So thank you guys for commenting. Um, but uh, there are contraindications for percutaneous mitral valve commissurotomy, and then I'll show some pictures of this on the next couple slides. So if people have a thrombus in the left atrium, that puts them at high risk of stroke. If they have leakiness or mitral regurgitation, that puts them at risk to have severe mitral regurgitation. So those are probably the two biggest ones. This is kind of a picture showing a percutaneous mitral balloon commissurotomy coming, the catheter coming up through the inferior vena cava, crossing this intraatrial septum, and then coming down to the mitral valve, where this mitral valve is really just a balloon that gets blown up. So you need to have very suitable anatomy with mobile, thin, and not heavily calcified leaflets of the mitral valve. So going back to what we talked about toward the beginning, this is really a better treatment for people early in the course of the disease or early symptomatic, as opposed to patients who are very late in the course of the disease that may have a whole lot of fibrosis or thickening and the mitral valve's not very mobile. And the contraindications, the main ones that I mentioned are clots in the left atrium and greater than mild mitral regurgitation. Uh, Pretty equivalent outcomes overall to surgery in terms of, improvement. And then only 1 to 3% have severe mitral regurgitation following. A low percentage of people develop a large pericardial effusion and tamponade. And then there is a good number of people that require reintervention over time. So using the Wilkins score is something to try to think about, but remembering the score isn't as important as to me as thinking about the people who are suitable candidates for the percutaneous mitral valve commissurotomy are people who have mobile leaflets, thin valves, and the subvalvular structures, or all those other cords, things that are wrapped up in the mitral valve. All those other, all those other structures are also thin and not thick or calcified too. Here's a picture from the cath lab. So kind of the grainy black and white pictures are echocardiographic pictures. And then the x-ray pictures are fluoroscopy in the cath lab. So you can see I think that the fluoroscopy pictures are the most interesting, as you can see where this went up through the IVC, across the intraatrial septum, and then going into the mitral valve. The balloon essentially blows up and then frees up the tethering of those mitral valve leaflets, and hopefully will leave you with a much improved valve. Additionally, surgical intervention, biologic and mechanical valves are kind of the two options. So biologic valve patients don't need anticoagulation, but mechanical valves last much longer. Anticoagulation always comes with a bleeding risk, but these biologic valves start to deteriorate even as early as 6 years following surgery. So oftentimes people that are younger will get mechanical valves because they're more durable, they'll last a lot longer, and people who are older will get biologic valves because they don't necessarily need them as long, and there's higher risks of anticoagulating people who are older. Medical optimization, as I mentioned, so rate controlling people with beta blockers, whether in pregnancy, whether out of pregnancy, diuretics to treat pulmonary congestion. And then one of the most important ones is after people have had rheumatic fever and carditis, using suppressive antibiotics to reduce the risk of having recurrences of rheumatic fever. So this is often with an injectable benzathine penicillin every 4 weeks. And then trying to loop back, way back, where we're thinking back into our primary prevention again. How do we treat patients with acute rheumatic fever and group A strep? So with strep pharyngitis, penicillin's preferred, penicillin V, penicillin G, or amoxicillin, but also cephalosporins and macrolides are often used. And then for acute rheumatic fever, IM penicillin is preferred, and otherwise oral penicillin if IM is not available, and then azithromycin. So for secondary prophylaxis, kind of treating people long-term with antibiotics intermittently. So would be usually treat people up to the age of 21 or the age of 40 to try to prevent features of carditis and rheumatic fever progression. And then thinking about some of these other long-term management, features after having a valve intervention. So patients should have prophylactic antibiotics before having dental work. People who are anticoagulated with a mitral valve, mechanical mitral valve, often have an INR goal of between 2.5 and 3.5. They should be seeing a cardiologist or a doctor annually to follow up. And since the bioprosthetic valves do deteriorate over time, having kind of serial echoes for those patients. And so I think I'm right about 45 minutes. I think I'm probably 5 minutes over the 40 minutes or so that I had, and this was a very broad overview of a lot of different topics and features to think about when thinking about rheumatic heart disease, and most specifically rheumatic mitral stenosis, trying to understand the epidemiology and pathophysiology, understanding prevention stages, and really thinking about primordial prevention or primary prevention from public health standpoints, treating the actual group A strep infection. Once patients have developed rheumatic fever, treating them periodically with antibiotics as well. And then also probably more in the realm of, I guess you guys as well, since you're seeing many people probably in their teenage years, I would guess, in the hospital or otherwise, treating the complications in terms of both medical management and then also chronic management that could include mitral valve balloon procedures or surgical mitral valve procedures, and thinking about the times that are really serious or can really flare people up, whether they develop atrial fibrillation or pregnancy. And then finally, understanding a little bit about the diagnostics such as echo, x-ray, your physical exam, and EKG, and then management as we talked about. And just a few points, I think I went over most of these on the last slide too. So rheumatic heart disease is secondary to infections with group A strep that are often seen in childhood. It's typically thought of as a disease of poverty and overcrowding. The pathophysiology is from commissural fusion, annular constriction, and subvalvular thickening or fibrosis, resulting in leaflet restriction. Mitral valve interventions are performed in severe stenosis in patients with symptoms, often atrial fibrillation, pulmonary hypertension, or progressive stenosis. that have severe symptoms on exercise. And then the percutaneous balloon mitral valvuloplasty is first line for valves that are thin and mobile without thrombus or calcification and less than moderate mitral regurg. So here's just a picture of my kiddos. So I think this is just a cute picture to share with you guys. I've got a 2-year-old and a 4-year-old, and they're painting a school bus, interestingly enough, that when we were in Florida. And then feel free, we can ask questions, review more specific parts of this. I can revisit slides if you guys would like, and then feel free if you want to give me some feedback, whether positive, negative, or just things I could have done to improve this. Feel free to take, a look at the QR code with your phone and fill out just a couple question survey on this as well.
Thank you, Dr. Sutter. That was great. Feel free to ask questions. Participants, if you're not able to unmute, you can quickly type them in the chat box, and I would be very happy to ask on your behalf.
And then I've got plenty of questions for you guys too. If there's not questions for me, but I'll give you a chance first, mostly so I can learn from you a little bit more about how you guys are treating rheumatic heart disease, and then also acute rheumatic fever, and kind of how frequent you're seeing patients.
You can ask your questions, Dr. Sutter. I will see if we get some group response.
Yeah. So what are your guys' mainstays of treatment for when you're seeing patients with rheumatic heart disease, when you're on the like inpatient wards? If people were to come in, are you guys, number one, diagnostics wise, are you guys treating reviewing, do you have a capability for echocardiogram? And then what medications are you guys using to treat patients most frequently?
Not sure if anybody's able to respond or just a shy group, but I can. I'm curious myself, so we can maybe follow back up with everybody and get a consensus and get back to you.
Okay, so I've got a comment from Dr. Gurma or Dr. Freezer Gurma. The ones we have follow up come get admitted for recurrence. So if they're getting admitted for recurrence, are you mostly treating them with antibiotics, or are you mostly treating the recurrence of rheumatic fever or recurrence of the heart disease, and you're mostly treating them with diuretics?
They do have echoes, so that's good.
Okay. Penicillin or benzathine penicillin or oral amoxicillin. Excellent. Okay. And are you guys seeing some of the, really complicated or really tough cases, like I mentioned, in terms of pregnancy or atrial fibrillation? Do you guys see patients with either of those complications? Okay, diuretics, aspirin, and benzathine penicillin. Okay. For recurrent rheumatic fever and decompensation. Thank you guys for chiming in and helping me out with that. It's a good chance for me to babies, only babies come in.
In our clinic, we use amoxicillin
Yeah.
instead of penicillin primarily for convenience.
Yeah.
This is effective. We feel
Yeah.
it is.
Yeah. That's kind of all the reviews that I was checking on this, because I don't prescribe too many antibiotics anymore except for before dental procedures. So everything I was reviewing, I agree with you, Dr. Downs-Bouchard, that everything was saying that amoxicillin is effective too,
Yeah.
for especially for outpatients or patients it's inconvenient for benzathine penicillin. Um, and then,
So
so remember, as young as 7 years old. Oh my gosh. So, and then my other question is then, for a really severe case of heart valve disease, are you guys able to refer people to a tertiary hospital? Are you guys to in a bigger city somewhere that can have access? Oh, amoxicillin's not working uh, for you in Ethiopia. Okay, and I'll have to do a little bit more digging on that. That may be that makes it difficult. Only few can afford intervention to Addis and some abroad. Do you guys ever see patients who may have been able to afford the intervention come back and are managing them later down the line with a biologic or a bioprosthetic valve or a surgical mechanical valve, or who've had treatment at a surgical center? And it's okay if that's rarely seen too. I know that this is um, still something that unfortunately the treatment's not available everywhere for everyone. And I primarily have worked with group in Rwanda, and they only have one cath lab in the country there, and they don't have access to cardiac surgeons. And actually, many of their cardiologists come from Ethiopia. So I think it's something that really just illustrates how important it is to be able to treat the group A strep up front and try to treat kind of relapses or recurrences of rheumatic fever. Okay. Well, thank you guys for commenting and being kind of engaging and help teaching me about this as well.
thank you so much, Dr. Sutter. This is a great discussion. I love the learning from one another. This was a really good review. I know it's a short amount of time to try to pack in a lot for a disease that does affect many. So we really appreciate your expertise and time. And I'm going to follow up and see if we have other questions. People can also send to us via email that we can, or use the QR code to continue the discussion going for sure. Thank you
Yeah, and
again.
I'm happy to share slides or answer other questions as they come up kind of further down the line too. My email address is there, and like I said, if you had ways that I could have made this better, feel free to let me know, and I can try to improve it for next time. So thanks so much.
Thank you so much again for your time. Have a great rest of your day, and I will follow up with you for sure. All right, we're going to be tuning over to our next lecturer shortly, who I believe is on the line, Dr. Rachel Martin-Blaise, who I believe is in Botswana at the moment, but is one of our pediatric infectious disease specialists here at Nationwide Children's Hospital, again in Columbus, Ohio. And Dr. Martin-Blaise did her medical training at Dartmouth and Mattel Children's, and she's also a member of the American Society of Tropical Medicine and Hygiene and Physicians for Human Rights. She has numerous and extensive global health experience and travel medicine experience, and has worked across the globe, including here in the US, the DRC, and Botswana, where she's currently working developing a pediatric infectious disease fellowship. And she's going to be speaking to us this morning on a review of some pediatric antimicrobial stewardship, which is a very important topic for all of us. Dr. Martin-Blaise, are you on the call? Let us know if you can, we can unmute your video. Oh, yes, thank you, great. And if you are able to share your screen, if you need any help with that, let us know.
Absolutely. I think I should be able to. Let's see. Um, Gotta do a couple maneuvers to make this happen. But hopefully I can get it going. Um, all right. Um, share. Okay. Are you able to see my screen?
Yep, thank you so much. Great.
Perfect. Okay. So I thank you so much for inviting me to come talk. I just wanted to go over some principles of antibiotic stewardship and also kind of make a case for some antibiotic or antimicrobial stewardship um, uh, activities that can be done in any setting. And to kind of emphasize the point that we've moved beyond just antibiotic stewardship into antimicrobial stewardship. I crossed out on this slide the biotic part of it because I wanted to emphasize that we are, it's not just antibiotics that are that we're developing resistance to in the world. We have antiviral resistance, there's antifungal resistance. Anytime you have any compound, there's going to be a selective pressure to become resistant to it. So we're mostly going to be talking about antibiotics, but just to keep in mind, this doesn't necessarily only apply to antibiotics. I don't have any relevant conflicts of interest. My spouse does have some stocks in a few companies. I'm not going to talk about anything related to any of those companies. And to be honest, I don't have anything to do with those stocks. I have asked him to actually get rid of them because I really don't like having to disclose them because I don't know anything about them, but just for your awareness. So going through the agenda, I'm going to go through some background, talk about what is stewardship, some opportunities for stewardship, and then stewardship in lower middle income settings, which I think there are really big opportunities for. So hopefully we can get to that. So going into the background, what's the big deal? Antimicrobials are one of the major discoveries of the last century, and actually they estimate that they are responsible for the extension of life by about 20 years expectancy, which is just incredible. And antimicrobials make other treatments possible, things like chemotherapy and transplantation. So it's not just infections that have benefited from it, but also all areas of medicine. The problem is, though, that they are a very limited resource. So resistance develops quickly, and we know that natural selection it drives resistance. Anytime there's selective pressure, you're going to get some organisms who are better or less equipped to adapt to that, and then the ones who adapt better live. The problem is, though, that we haven't really been discovering new antimicrobials. There was a big push there was not really a push, but I guess there was a renaissance of sorts where we had one antimicrobial that was discovered and then many antimicrobials, and it was really blossoming, and then it sort of trickled off. So when you look at this diagram from the UK Public Health Service, you can see that almost as soon as we developed antibiotics, we've discovered resistance to them. So in only, 10 years, but sometimes less than 10 years after the antibiotic starts being used, we see that the resistance develops. And over here on the right-hand side, you can see that in the last 20, 30 years, we really have not developed a lot of new classes of antibiotics. So unfortunately, not only is the resistance developing quickly, but we don't really have, we're kind of just doing riffs on the same themes. We're developing new antibiotics that are sort of related to previous antibiotics, not developing whole new classes. And so it's not that hard for resistance to develop. And the other part of this is that most of the antibiotics that we have developed came from natural sources. So a lot of them came from actinomycetes, actually, and other bacteria. But fungi also have been the source of many of our antibiotics and antimicrobials that we use. Only a few of them are synthetic, and actually a lot of the are you still able to hear me?
Yes, just had
Okay,
2 second blur.
Okay, something weird just happened, but I think we're okay. Yeah, the majority of our agents are just things that we found in the environment, but now we've tested a lot of things and we're sort of slowing down on the compounds that we're finding. And in terms of discovery of new classes of antibiotics, you can see that in the 40s, 50s, 60s, we were discovering a lot of classes of antibiotics, but then it's really trickled off towards the 90s, 2000s, and today. The Carbex really hammers this point home that half of antibiotics used today were discovered during the 1950s. And every antibiotic in use today for gram-negative infections the discovery of that antibiotic was made prior to 1962. So we are really lacking. But I do have some more information later that'll hopefully be a little bit more hopeful. The other part of this is that even where we have antibiotics or antimicrobials, a lot of them are not available everywhere in the world. And you can see here, the countries with darker colors are countries where more antimicrobials had filings for registration. And so there are some countries that have none. So Somalia and South Sudan, for example, really have no registrations for antimicrobials being filed. And so a lot of them are unavailable or not accessible. And then even in countries where the antimicrobials are filed, it may be lower numbers than in other countries. So there's a huge differential of where drugs are accessible, even if they exist. In those settings where fewer drugs are available, there's going to be a more limited number of drugs to choose from. And then it's that much more important that you save your antimicrobials as possible, because there's only certain drugs that you can kind of step up to. But I think part of this also argues for drug companies need to be more equitable with where they are going and registering their drugs. And I know that they are motivated by profits. So they go to the places with the highest populations and the most likely to use a lot of their drug. But there are some people who are trying to combat this a bit too. Antimicrobial resistance, in addition to kind of the way that we think about it impacting an individual's health, also impacts the community. And this was a WHO report talking about how antimicrobial resistance threatens our whole world's ability to attain the Sustainable Development Goals. And of course, most of it is focused on SDG number 3, which is good health and well-being. Because of the obvious reasons, antimicrobial resistance directly threatens that. But it also threatens other goals as well, or is impacted by other goals. So poverty is very much affected by antimicrobial resistance. People who are in poverty are more likely to have infectious diseases, or more likely to be exposed to infectious diseases, and then resistant infections can spread in populations in poverty, particularly people who are living in close contact with each other. And then the high cost of treating those infections really prevents a lot of people from getting appropriate treatment, which perpetuates the resistance. Same on a broader sense, hunger-wise, the antimicrobial resistance that affects cattle and our food supply also affects humans. And then clean water and sanitation affects our ability to control antimicrobial resistance, and economic growth is impacted as people are ill and are not able to afford treatment. So there's sort of a two-way relationship between antimicrobial resistance and the Sustainable Development Goals, where a lot of the challenges that the goals try to address also can cause or perpetuate antimicrobial resistance, and antimicrobial resistance can cause some of the challenges meeting our goals. In terms of economic impact, this was from the World Bank looking at scenarios where there's high antimicrobial resistance, which would be the yellow dotted line, and then a lower forecast of antimicrobial resistance into the future. So at the 100 line is where we currently are in terms of our gross domestic product globally. But you can see if there's a low antimicrobial resistance scenario where we have more resistance than we have currently, but not a ton, the gross domestic product globally falls by about 1 point by 2030, and then 1.1 by 2050. But if we have the high resistance scenario, then we expect it would probably fall more in the order of 3 by 2030 and 3.84 by 2050. And this is more pronounced in low and middle income settings where it's closer to 5 probably. And most of the people who fell into poverty because of antimicrobial resistance would most likely be in low and middle income countries. So you can see that by 2050, in the high AMR case, there's an expectation that there might be 28 million more people falling into extreme poverty, and most of those people would be in the low and middle income countries. So it's definitely something that has a potential for a huge impact. And when we look back at the 2008 financial crisis and compare the potential impact against the 2008 financial crisis, the high AMR scenario would be an even worse impact than the financial crisis that brought stock markets, kind of the whole economy crashing. The low AMR scenario also would be not good, but not as bad as the crisis. But you can see here too that the low and lower middle income countries would be more heavily affected, most likely. And just to show that this impact spans multiple areas, not just human health, this is a graph looking at livestock production, which would be a big component. And in the low AMR scenario, we would definitely still see impact on livestock production because of antimicrobial resistance in our livestock. But in the high AMR scenario, it would be quite pronounced, so probably about 5 points down. And in lower middle income countries, more like 10 points. It was really a big impact. So that just gets to the point that antimicrobial resistance is not just a human problem, but a One Health problem. So if you focus just on the red part in this diagram, the people and human-to-human transmission of resistant organisms, then you're really missing out on a huge component of this, because our land and how we use our land affects our livestock, and our livestock affects the antibiotics or antimicrobials that we give our livestock can get into our food supply and affect us. We can also put antimicrobials into the water system, and it can have effects on the wildlife there, and vice versa. So there's a big interplay between all areas of the environment and our health. And this is sort of emphasized by this graph, which shows on the y-axis, you can see the relative contribution as a driver of antimicrobial resistance, and the x-axis is evidence that that factor contributes to resistance. And human antimicrobial overuse or misuse is the highest, both for evidence and relative contribution, but you can see animal use and misuse is right up there with humans. And then environmental contamination, suboptimal diagnostics, suboptimal vaccination, travel, suboptimal dosing of drugs, are all kind of in the moderate range. Mass drug administration for human health probably has some contribution, but there's low evidence for that. So all of this is to say, this is not just a human problem. This is a One Health problem. But I think that the team probably is aware of that because this whole lecture series is part of the Go High group, which focuses on One Health. So going back to humans, the WHO put together a list of, every year actually, they put together a list of the organisms that are most critical for human health and most likely to for antimicrobial resistance to cause a problem. So currently the most worrisome contributors are Acinetobacter baumannii and the Enterobacterales, including E. coli and Klebsiella. They are rapidly developing resistance. They can have resistance that in some cases is almost impossible to treat, and it's really widespread. Other things like Salmonella, Shigella, Enterococcus, Pseudomonas, gonorrhea, Staph aureus are all on the list as well. They're in the high risk group. And then lower down there are the group A strep, group B strep, strep pneumo, and H flu. Interesting that someone said that amoxicillin doesn't really work for prophylaxis for rheumatic fever in your population. It should be susceptible. So if there's penicillin susceptibility, amoxicillin susceptibility should be kind of a given. But I'm wondering if maybe there's some adherence issues that might be causing a problem, which sort of gets to the antimicrobial stewardship part of things. And looking at the changes between 2017 and 2024, you can see that Acinetobacter actually has maybe become a little bit less of a concern than it had been in 2017, but Klebsiella and E. coli have really jumped up the ranks, as well as Salmonella, like typhoid fever, Shigella, and gonorrhea have really hopped up quite a bit. And then some of the other organisms, like Enterococcus, have remained about the same. But the main focus recently has been Klebsiella pneumoniae, particularly because carbapenem resistance has been taking off. Antimicrobial resistance, in addition to being a local, an individual threat and a more broad population threat, is also a health equity issue, because we know that lower middle income countries are more affected by antimicrobial resistance. And we can see that in this, from the GLASS report from WHO in 2021, that lower middle income country groups tended to report higher proportions of patients with resistant E. coli UTIs, and then higher rates of MRSA as well. And when we look at all age rates of death attributable to and associated with resistance, you can see that sub-Saharan Africa really comes out at the top here. So they have the highest number of attributable and associated deaths with antimicrobial resistance. So it's definitely a big problem for sub-Saharan Africa overall. When we look at children under 5 and deaths associated and attributable to antimicrobial resistance, you can see that Western sub-Saharan Africa has the highest absolute number of deaths, followed by South Asia, but Eastern sub-Saharan Africa, which would be where Ethiopia is located, it ranks 3rd, and the number of attributable deaths is approaching 10,000, with the number of associated deaths about 30,000. This is for children under 5 years old, so that's still a pretty large number of children that are being affected by antimicrobial resistance. So it's not just something that we worry about in adults, although I think that sometimes people tend to construe it that way. So what about Ethiopia in particular? looking at communicable diseases, I've highlighted Ethiopia here, and when looking globally at the global burden of disease study in individuals 0 to 24 years of age, you can see that Ethiopia has a particularly high burden of infectious skin conditions, as well as malaria, upper respiratory tract infections, but a lot of communicable diseases. And when we put this into context of other countries, for this age group of 0 to 24 years, Ethiopia is number 4 for enteric infections, number 4 for lower respiratory tract infections in children and adolescents, number 6 for tuberculosis, and number 5 for HIV and AIDS. So there's a huge potential. There's, first of all, a huge need for antimicrobial use, but then also a huge potential for resistance if drugs are not used in the most responsible manner. And looking at antimicrobial burden or resistance burden in Ethiopia, in 2019, there were 21,000 attributable deaths and 85,000 associated deaths, which puts Ethiopia at the 35th highest age standardized mortality rate across all countries in the world. In the Eastern Sub-Saharan African region, Ethiopia does quite well, actually, compared to all of your neighbors. It has the 3rd lowest age standardized mortality across 15 countries. But when we compare it to other causes of death, antimicrobial resistance is one of the top causes of death, higher than maternal and neonatal disorders, cardiovascular disease, respiratory infection, TB, and neoplasms. And when we break it down by the composition of infection-related deaths, you can see that out of 168,000 bacterial infections that were causes of death, half of those had associated resistance, meaning that there was some resistance that probably played a role. And for a quarter of those identified as having some resistance associated, the death itself was actually attributable to antimicrobial resistance. So there's a very big burden of resistance. And when we look at E. coli, we can see that the proportion of bloodstream infections resistant to 3rd generation cephalosporins has varied quite a lot, but has been pretty high. Most recently in 2021 is about 86%. And then looking, this is just a diagram looking at pathogens and antibiotics, and which antibiotic resistances and which pathogens are most important in Ethiopia. And you can see that resistance to aminoglycosides, carbapenems, fluoroquinolones, methicillin, 3rd generation cephalosporins, and trimethoprim are particularly big concerns. And then in terms of organisms, as I kind of mentioned before, Acinetobacter baumannii, E. coli, TB, Klebsiella, Staph aureus, and Strep pneumo are the most concerning pathogens causing the highest absolute number of deaths for all ages. When we look at total consumption of antibacterials, Ethiopia does a great job. You can see compared to your neighbors, the absolute consumption of antibacterials is much lower per 1,000 inhabitants per day. And the most commonly used ones are macrolides like azithromycin, lincosamides like clindamycin, and streptogrammin. Okay, so going into antimicrobial stewardship. So what is stewardship? This term was first used in 1996, and it was meant to sort of balance the individual and societal needs. And then it sort of grew with the One Health movement into also addressing global needs. So the goal with antimicrobial stewardship is long-term sustainability. The stewardship term was actually inspired by the Bible, the Gospel of the Good Steward, to say that antibiotics are a non-renewable resource and they should be used when they're needed, but avoided when they're not, because we're trying to maintain them for all the population in the world. And And Dr. Alexander Fleming, who won the Nobel Prize for discovering penicillin, said in 1945, "The microbes are educated to resist penicillin. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted." So our goal is to avert unnecessary deaths by protecting our antibiotics and their efficacy. So this goes across all levels of the health system. So from the patient to the nurse, the doctor, the pharmacist, the hospital administration, and the government. So for the patient, we want the patients to understand the risks of antimicrobials and not self-administer them without medical guidance. We want our nursing staff to help counsel patients on appropriate use and administer the antibiotics or antimicrobials correctly. Doctors, of course, we want to make sure that we are counseling patients appropriately, but we're also diagnosing the correct disease, prescribing responsibly, and following up and adjusting as needed. For pharmacists, we want to make sure that the pharmacy team is storing and providing antimicrobials when asked. They're reviewing antimicrobial use and then educating patients and the medical team on the responsible use of antibiotics and antimicrobials. The hospital administration should be on the team, making sure that they're monitoring antimicrobial use, providing decision support and funding stewardship programs to try to help improve our use of antimicrobials. And then the government should be having everybody's back by regulating the drug companies, making sure that medical professionals are appropriately trained and licensed for prescribing antimicrobials, and then prioritizing quality care and writing laws to govern antimicrobial use across different levels. So stewardship is sort of a big feedback loop, and that all of these players interact on various levels of the system. So it's very complicated. It's not as simple as just changing your own behavior. It's changing behavior on a big scale as well. And this was an analysis done by the WHO talking about readiness for antimicrobial stewardship in a healthcare facility. So it's very important that the leadership is on your side. There's enthusiasm in the ward and an individual level. There's also people understand what the goal of stewardship is. And you have data to be able to work with. So you have a way of collecting use of antimicrobials and then reflecting on it and changing, and then collecting data on it after the fact to see what changed. On sort of external or bigger scale level, there should be places for these findings to be presented, to influence other organizations and other providers. There should be a national program for antimicrobial stewardship and health. And then there are ways that our institutions or our colleagues can sort of work against us. So if there's no medical record, there's no monitoring of antimicrobials or ability to follow up on antimicrobials, then it's really hard to do this work. If you can't do the testing to figure out what is going on, then it's really hard to do this work. Or if your supply of antibiotics is poor and you only have one option, that also can make it quite a challenge. So you need to have support from all levels and also people ready to do the work on all levels. So for individual and community stewardship, we think of the rights. So we talk about the right diagnosis, the right drug, the right dose and route, and the right duration. And when thinking about the first piece, the right diagnosis, I know for me, working in low and middle income settings, I know that it can be really a challenge to get the right diagnosis because often you don't have the diagnostic tools that you want. And so you're relying on sometimes no diagnosis or no diagnostic ability, and sometimes less ideal diagnostic ability. So for example, I was trying to diagnose congenital CMV the other day, and we don't have a CMV PCR. So we were going off of CMV serology, which is a bit problematic in a newborn infant. So it can be a real challenge just by virtue of not having diagnostic tools available. But then also the way that we use our diagnostic tools can really affect our stewardship. So for example, for the testing of C. difficile, if you test in the wrong environment, say you test an infant who is likely to be colonized with C. difficile, and you get a positive result, and you don't know how to interpret that correctly, then you might make the mistake of treating that infant when in fact it's not a true infection. So some things that we can set up in our diagnostic process can help us avoid making those wrong diagnoses. Things like making sure that it cannot be ordered. C. diff, for example, cannot be ordered when somebody has a firm stool, or there are comments on the result that say, if this is an infant, then the likelihood of this being true C. diff is low, correlate with clinical signs. Things like that can sort of remind us and remind all people across the health system to sort of stop and think and not just take a result for granted. When we're thinking about ways to improve antibiotic prescribing, we're really looking at things like overprescribing, so prescribing when it's not needed, either because we haven't confirmed a diagnosis or we have the wrong diagnosis, doing overly broad antibiotics or antimicrobials, or giving them at the wrong time. So doing really long surgical prophylaxis, for example. Choosing the wrong antibiotic for an infection or giving the wrong dose, giving it via the wrong route or for too long sometimes can also be a problem. And then unnecessary combination therapy, using drugs that have overlapping spectra, we try to avoid. I know in the past there were some recommendations to do that, but a lot of more recent studies have shown that you probably don't have a lot of benefit in most cases, especially once you've identified what the problem is. The exceptions being, for tuberculosis, to having multiple drugs, and you can perpetuate some of the resistance. And then delaying our antibiotics. So starting antibiotics, but maybe not giving the next dose on time, you can also perpetuate resistance. Some of how we can combat that is coming up with local treatment guidelines. And this takes into account the local epidemiology and also the resistance patterns to try and give guidance on what the appropriate first-line therapy in most cases should be. There's also regional guidelines that can help with this, and the African CDC guidelines. I love these guidelines. I think they're really excellent, looking for across the continent. And then on a more global scale, there's the WHO guidelines. I don't know if you all have heard about the WHO Aware antibiotic book, but it is one of my favorites. It not only gives you sort of empiric recommendations for treatment, but also, and clinical syndromes, but also categorizes drugs into categories. So the access antibiotics are the narrow spectrum. They have low cost, they're very safe, they have low resistance potential, and those are ones that should be easily available and are often given for very common infections. The watch antibiotics are broader spectrum. They may have higher costs. They may be harder to administer, and they really are only for cases where someone has failed first-line therapy or you think that they have a resistant organism. And then reserve antibiotics are your last choice. You've already gone through the first couple, or you know that they have a massively resistant organism, where you need to step up quite a lot and maybe give them something that's more toxic or difficult to monitor. And this is an example of one of the infographics from this book. This book is available for free online. I very much recommend you all look at it if you have a chance. But this is the community-acquired pneumonia page for children. It goes through the most common typical bacteria and clinical presentation. And then on this the treatment page, you can see that they've broken it down into different recommendations for treatment. So for mild to moderate cases, it's amoxicillin, which is in green because it's an access antibiotic. It's narrow spectrum. We give it all the time. And then second choices you have in yellow. So those would be the broader spectrum third generation cephalosporins, or if you have a patient with HIV, then trimethoprim for potential pneumocystis. And looking at relative consumption of antibacterials by classification in Ethiopia, you can see that the goal is that the majority of your drugs that are given are in the access category, at least 60%. You can see that Ethiopia is split about 50-50 between access and watch, and actually watch antibiotics are a little bit more commonly used. So the goal would be to move more towards using the lower level antimicrobials more commonly to try to preserve the upper level antimicrobials. This is all sort of outlined in the WHO policy on integrated antimicrobial stewardship activities, and it talks about how to implement stewardship on a sort of broad level. We'll kind of skip through this though, because time is running short. And then there's also the Global Action Plan on Antimicrobial Resistance, published by the WHO in 2015, which goes through goals on improving awareness and understanding of resistance, strengthening the knowledge, reducing infection through WASH procedures, and then optimizing the use of antimicrobials and encouraging economic incentives to align to help antimicrobial resistance prevention. Okay, so opportunities for antimicrobial stewardship. So this is from the WHO. This is just basic AMS interventions that anyone can do at any level of the health system. And you can start today. The first one is educating prescribers and health personnel on antibiotic use. Very basic, just kind of going through making sure everybody is on the same page of what are our first line antibiotics, who should be treated with antibiotics and who should not, how do we make sure that we're using our antibiotics most effectively. Number two is developing and updating a standardized medical record to make sure that every patient has the same information in the same place, so it's easy to access and compare. Then review whether patients who receive antibiotic treatment have written indications for that treatment to make sure that everybody is sort of justifying their use of antibiotics. If it can't be justified, then you're going back and stopping antibiotics. And that's this point number 4, reviewing the treatment. And particularly for patients who have 3 or more broad spectrum antibiotics, you want to go back and review and make sure that they're all indicated. Reviewing the dose, making sure that surgical prophylaxis is appropriate, if it should only be single dose or 24 hours, not continuing beyond that. Then developing local guidelines for common conditions, which we had talked about previously, making sure that leadership has been identified and infection control management is pointed out so that everyone knows who to go to or who to look to, and how to sort of have review and feedback. And then improve supply and management of medicines by establishing a drug and therapeutics committee, working to establish basic micro lab facilities, because of course your diagnosis is only as good as your diagnostics. And then making sure that you have regular surveillance activities to sort of reflect on this. And this is a lovely study actually done by some of my colleagues who work in Ethiopia, looking at the need for partnership across multiple levels to implement some of these antimicrobial stewardship intervention. So in this intervention, the pharmacist and an infectious diseases specialist did immediate audit and feedback with teams on the ward once a week for 40 weeks. And then after that, they stopped doing audit and feedback with the teams, but they would still audit the antimicrobial use offline. They just wouldn't talk to the team about it. And then they looked and saw what happened when the audit and feedback was happening, and then what happened when they stopped giving feedback to the team. In half of cases on the ward, more than half actually, 54% of cases, the antimicrobial stewardship team recommended discontinuing antibiotics that were being used. You can see that during the period of the intervention, the use of antibiotics was much lower. And then after the intervention ceased, people picked it right back up again and started using more antibiotics. Despite the antibiotics being lower, though, in the first part of this intervention, the hospital stay was shorter, probably because people weren't needing to stay for antibiotics, but also the death rate was lower. And even when they adjusted for the diagnosis, like there was more febrile neutropenia in the post period, for example, it still persisted that the death rate was lower. So that's all to say that it is very easy to revert back, and antimicrobial stewardship at its heart is really a quality improvement project. So it's important that you do this plan, do, study, adjust cycle, PDSA cycle throughout. And then looking at other opportunities. So I think that we're in a really interesting time in infectious diseases right now. This paper is talking about how in the past, a lot of the recommendations were based on dogma. So people just said, oh, we treat for 21 days for meningitis. And everyone said, okay, we do that. And that's what we did. And IV was considered better than oral. And so everybody was treating with IV therapy. But looking back on this timeline, so the 1930s was when antibiotics were discovered, and then the 1940s to 70s, we were relying on expert opinion of best practice. So that brought this period in the 50s to 2000s where it was really on dogma. And then even though we developed these new ways to look at antibiotics, we kept reinforcing these previous patterns because we would say, well, when we study 14 days of antibiotics for bloodstream infection, people get better. But people didn't compare it to a shorter duration of therapy. And so now, from the 2000s onward, we've started to question some of these previous assumptions. And doing some modern study designs, we're starting to realize that we probably were overdoing it in a lot of previous cases. And relying on expert testimony or relying on just people's opinions of how long we should treat is really not doing our patients any favors. So when we compare shorter versus longer therapy, there's no difference in outcomes for any of these diagnoses that you can see on the side. Pneumonia, ventilator or community-acquired, UTI, intra-abdominal infection, bloodstream infections, wounds, osteomyelitis, septic arthritis, neutropenic fever, all of these show that actually when you do a shorter duration of therapy, your outcomes are about equal. In some cases, they're improved, like in the SCOUT-CAP trial, which looked at pneumonia, the outcome was improved because you had less exposure to antibiotics and fewer side effects from your antibiotics. And then looking at randomized trials of oral versus IV, again, the outcomes were all equal or superior for oral therapy versus IV therapy. We are realizing that a lot of our previous assumptions were wrong. But I think that this is important because I think this is an area where lower middle income countries really have an opportunity to make a meaningful change in this era where we're starting to realize shorter is better and oral is better. And looking at the references cited in this paper, a lot of them came from lower middle income countries. And when we look back at certain things like pneumonia, for example, a lot of studies based in lower middle income countries looked at duration of therapy for pneumonia in children and found that there was no difference in 3 versus 5 days for non-severe pneumonia in kids under 5. Yet, in high resource settings, we had been doing 10 days of antibiotics because that was what was recommended by a panel of experts by the IDSA. However, when we finally retroactively went back and looked at it with the SCOUT-CAP trial, that's when we found that 5 days was actually superior to 10 days. So the low and middle income countries had been leading the way on this. And if the high income countries had paid attention, we probably could have saved a lot of kids a lot of trouble. This is also sort of reflected in some of the newer studies, like the SHINE trial for non-severe tuberculosis, which showed that 4 months was equivalent to 6 months for young children with non-severe tuberculosis or possibacillary simple disease. And so this has pushed us. I know that some countries kind of jumped on this and started going to 4 months quite early. The US just converted very recently, like a couple months ago. So this is another area where this low and middle income countries have been leading the way. So in terms of other sort of new frontiers, I think we might be able to see that oral is better and shorter is better. So neonatal meningitis, the observational data has really guided us on the 14 and 21 days for neonatal meningitis, but we really don't know. And one RCT said that maybe 10 days might be adequate. There were some problems with the RCTs. Actually, none of them had positive CSF cultures in this case, but I think that does just sort of argue for, we don't really know what we're doing. We're making this up. And then we've all sort of stuck to that. There was a systematic review that showed that the duration really varies across practices, and there's no data to suggest one particular duration. So there's a great opportunity to study outcomes based on current practices and to publish that and to show the world that maybe we're overdoing it in some cases. Same thing for bacteremia. We historically treated for 10 to 14 days, but more recent data is saying probably 7 days is accurate. And there is evidence that a potential for oral step down could really be the next frontier. So, I think in areas where it's hard to get IV therapy or it's hard to do that duration of therapy because of resources, those might be good areas to try to look at some of these things and to try to prove to high income settings that maybe we've been overdoing it for a long time. In terms of oral therapy, there's some data. So brain abscess and meningitis, we've always thought that it needs to be IV, but Lyme is treated with oral doxycycline, and there's some data saying that oral therapies could be used for brain abscesses. We really haven't explored it. Same thing for bloodstream infections. Like I said, oral step down is probably reasonable, and now in infants, we're doing step down to oral therapy, even for bacteremic UTIs, which was unthinkable not too long ago. Endocarditis, they're now doing step down to oral therapy in adults, and there's no data in kids. I think this would be a great opportunity for further study. And then in terms of testing techniques, a lot of low equipment testing techniques hopefully will be rolling out in the next few years. So I think this is kind of a time to shine where high resource really does equal high waste in a lot of cases. And thoughtful antimicrobial use can minimize harm and excess therapy while maintaining or even improving outcomes for our patients. And it can decrease our socioeconomic burdens for families, decrease selective pressure on microbes, and minimize our healthcare system's environmental impact. So this is an area where we really can make big strides. There's also a movement to sort of decentralize some of these guidelines and to get feedback from more people, because I think the same experts have just been weighing in over and over and over, and it's time to open it up to the world. So like the Wiki guidelines movement, for example, is a crowdsourced approach to infectious diseases guidelines, and anybody can access it from anywhere in the world, but also anybody can make comments and anybody can give feedback. So hopefully that will allow more international participation, but also make guidelines more universal, help us share data and give more say to low and middle income countries. Okay, so going back to how to advocate for stewardship in your setting, just looking at like basic things that healthcare workers can do. Preventing infections by washing your hands, washing your environment and your instruments, keeping your patients' vaccines up to date. Make sure you test to confirm an infection before you're treating it, and only prescribe antibiotics when they're truly needed. And then make sure that you're dispensing the right antibiotic at the right dose and for the right duration. And this one, as I mentioned, is the area that I think there's a lot of new exciting potential to look at further. Just thinking about where resistance comes from, as I mentioned, it's all levels. So it's not just us with our patients, although sometimes it can feel like there's a lot of pressure on us. It's also in the greater community. So the responsibility lies not only with individual providers, but with institutions, with the government, with our veterinary colleagues and our environmental colleagues, and with the drug companies who need to make new antibiotics for the cases where we run out of options. And then it spreads at all levels of the community as well. So this is some advocacy materials from the WHO's World Antibiotic Awareness Week in 2018. They do one every year. It's usually in November. Look out for it this year. They changed it to Antimicrobial Awareness Week to emphasize those antifungals and antivirals too. But it's important for us all to be good stewards, to make sure that we are using our antimicrobials with care, and we are giving them when they're needed, but also responsibly withholding them when they're not. And this is just a little bit of hope, showing that over the last few years, we have had a lot more antibacterial agents coming out. There's more funding going towards them. There's some new partnerships to try to improve the drug development as people have become aware of this problem. And if you have any interest in learning more, this WHO course on antimicrobial stewardship is free. It's at the Open WHO website, and you're welcome to participate in this. I very much enjoyed it. And if you have any questions, I'd be happy to answer them. That's my email and my WhatsApp.
Thank you so much, Dr. Martin Blaze. That was excellent, and gosh, I learned so much. I'm humbled by this as a provider. So many reminders of what we do and how we do it, and doing no harm, so to speak. I think we all want to help people get well, and when we see an infection, we're excited that we have something to treat with. But it's very humbling to think that sometimes we can do more harm than good. I know we're running short on time, but this was such an interesting discussion. I'm very happy to see if there's any questions. I was just curious myself, Dr. Martin Blaze, if you knew the data on countries and communities where antibiotics or antimicrobials are over the counter, so to speak, meaning not requiring a doctor's or provider's prescription. Do we see worse rates of antimicrobial resistance, or is that data not known? I know in this country we can't purchase antibiotics without a provider's prescription.
Yeah, there is a relationship between over-the-counter antimicrobial provision and resistance, and so that's been one of the pushes from the WHO in their recommendations for stewardship is creating a sort of barrier to people getting antibiotics, so that someone who's been trained on stewardship, a provider at any level, is standing between antibiotics and the individual to try to help mitigate that. And I know I actually was reading through a really interesting USAID paper talking about a program in Ethiopia where the antimicrobial stewardship had been emphasized, and there had been a switch from providing antimicrobials without a prescription to providing them with a prescription. I don't know if anyone knows about that or can comment about that, but it seemed like that was a big change, but it seemed like it made a big difference.
Thank you again. I think we could probably talk about this for hours. But I'm cognizant of your time. And are there any questions? And you can certainly put them in the chat box, or even if you have them after the fact, if you email one of us, we'd be happy to get back to you. You know, sometimes it's hard to think of the question and type it in quickly in this format. One of these days we'll do this in person because it's always a little bit easier interaction, but it's great to reach such a large audience. Well, thank you again so much. I look forward to working with you again, and I'll keep you updated if questions come after the lecture. We will get back to you. Thank you again. That was very informative. Excellent.
Thank you so much. I really appreciate you all inviting me. And please do email or WhatsApp me if you have any questions or if I can help with anything. I know one of my colleagues is in Ethiopia right now, and he might have worked with several of you, Tinsei Alamayu. He's also, I think, in country right now, if you all want to ask him any questions or if you have his contact information, but he's an excellent Peds ID physician.
Great, thank you. That's awesome. Thank you again. All right, I think we will, for the sake of time, move on to our next lecturer. It looks like our next lecturer, Dr. Hunter Wynkoop, is on the line. Hunter, if you're there, you can, if you're able to, unmute yourself or...
Hey, Tracy. Yep, I can hear you.
I really appreciate you being here today. And you're going to be speaking to us on pediatric fluid therapy, I believe. Dr. Wynkoop is one of our pediatric critical care physicians here at Nationwide Children's Hospital, but also works abroad, specifically in Malawi and the DRC. She's done a lot of research on specifically cerebral malaria and respiratory distress in African children with cerebral malaria, multi-organ dysfunction, and has had extensive experience both here in the United States and abroad. We're privileged that she's here today. She could probably speak to us on many topics on pediatric critical care. We kind of picked one for the sake of time. I think something that we all love to hear more about and review on again is basically managing fluid therapy in children. So I will turn it over to you. And again, feel free, everybody, if you have questions during the lecture or after, you can put it in the chat box. If you can't, raise your hand and I can help get those answered. Thank you again. I'll turn it over to you.
All right, I'm just going to share my screen here. And then, Tracy, is it just the slides or is it the whole presenter view that you're seeing?
Looks like the whole thing, I think.
All right, that's fine. Let me do it this way then.
Well, yeah.
Is that better?
Yes.
Okay, perfect. All right. Well, thank you all so much for this opportunity. Like Tracy said, I'm one of the ICU docs at Nationwide Children's, and most of my experience in Africa has been in Swaziland, Malawi, Zambia, and the Congo, the DRC. And so there's so many wonderful physicians in those countries that we have the opportunity to work with. And so doing things like this, I absolutely love and appreciate the opportunity. I must confess, doing fluid therapy is an essential thing to talk about, but it's not always the most exciting. So I'm going to try to incorporate a few different interactive places of it. So if you have like a pen or paper, just for your calculations, because as we all know, pediatric medicine involves a lot of calculations since everything is weight-based. So if you want to have that ready, there'll be a couple opportunities throughout. So today we're just going to talk about the basic concepts of fluid therapy, review which type of fluid is best for the patient, maintenance fluids calculations, of course, and then talk about the most common types of dehydration and then specific management for each of those. So water is the most abundant component of the human body, and total body water as a percentage changes with age. So for example, fetus has like 80 to 90% total body water. And then a preemie is going to have more than a term infant. And so as we get older, so ages at least 1 years to 12 years, we get closer to like what an adult is from a total body water percentage. But during dehydration, your total body water is what is affected, and that's what's making the change in your body weight. Our total body water is divided into two main compartments. So you have your intracellular fluid and your extracellular fluid. Now, this is a little bit of a review from medical school and just basic physiology, but it's important. And this changes in pediatrics. So in newborn, the extracellular fluid component is actually larger than the intracellular fluid component. But by 1 year of age, this ratio switches and is similar to what you see in adults as well. So this is in like a picture version as well as a chart, just depending on how you best read it and can see it. Excuse me. So a term neonate is what I was just saying. So you have an 80% total body water with your extracellular fluid of 45%, intracellular 35%. And then as they become a year old, up until adults, you can see that the extracellular fluid becomes less than the intracellular fluid. And down at the bottom is the same representation. And then within the each fluid compartment, it can be further divided. So specifically the extracellular fluid. So you have your interstitial volume and then your blood volume or your volume of plasma. Now these things, so your volume of plasma can be altered by a variety of different mechanisms. So in pathologic conditions, this is when you have a severely anemic child, or you have the other direction and they're polycythemic. Maybe you have heart failure or just abnormal plasma osmolality. This is when you see effects here. And so your interstitial fluid can increase also dramatically in certain pathologic conditions. So I think about liver failure, nephrotic syndrome, different causes of hypoalbuminemia, sometimes heart failure as well. So these different components or compartments can be affected based on the pathology. The important aspect of that is that each compartment also has different electrolyte just like prevalence. So for example, your intracellular fluid is where a lot of your potassium is. So your potassium content is very high there compared to your extracellular fluid content. That's where your sodium is hanging out, your sodium and your chloride. So depending on what compartment is affected also can depend on which electrolytes are most affected. So let's see. In general, the water loss sources, you can kind of divide it up into like your insensible losses and then your measurable losses. When I think insensible losses, I think about, I'm also an ICU doctor, so I think about the extremes. So I think about burns or like children that are requiring warmers, especially small kids. Phototherapy in the little hyperbilly babies, fevers are a great source of insensible losses. And then your measurable losses make up about 65% of your fluid losses, and that's your urine mostly, and then also your stool. Of course, when you're sick, your insensible losses and other losses increase. So that's because of, like I was mentioning, your fevers. What about like seizures? They increase insensible losses a lot, and part of that just has to do with the increased metabolic activity as well. When kids are vomiting or if they have a nasogastric tube and they have a ton of output, those conditions will also increase your losses, of course. I often think about when I'm talking about or thinking about fluid management, for me, I almost think of like a bathtub or a bucket of water where you have a faucet of what's coming in, and then maybe you have a hole in the bottom or a drain of what's going out. And so essentially you're just trying to keep up with how much is coming in and how much is going out and to keep those things balanced. The interesting part of pediatrics is that kids are just at higher risk of water losses and dehydration. Part of that has to do with their high metabolic rate, or just the increased rate of ketosis, how often they eat, what their body composition actually is, and the amount of water involved. And then some of it is there's faster respiratory rates, things like that. And so those can increase your insensible losses. So there's just a lot to think about from a pediatric standpoint that's very pediatric specific. And that is even more increased when you think about infants. So you could give fluid therapy talks all day based on certain age groups or pathologies. So like newborns can have their own talk about fluid therapy. Kids with AKI can have their own talk, or heart failure, or liver failure, or burns, or trauma. So this is not all inclusive, but just like a overall thought process of what to know as you're managing kids. So with that in mind, not diving too deep, but infants in general are just more susceptible for water loss. And some of that just has to do with their kidneys are still quite immature. So they don't concentrate their urine very well. So they lose a lot of free water. They also have higher metabolic rates and larger body surface areas. So those things contribute greatly to how quickly infants lose water. So why do we use fluid therapy? When you think about fluid therapy, I think one important thing is to think about it as your goal is to correct your body water and your electrolyte disturbances. We are trying to essentially just maintain homeostasis, maintain your blood volume, the osmolality, the pH, the electrolyte composition, and just restore normal physiologic function. That is the goal of fluid therapy. And it really is therapy. We should think of IV fluids as if they're drugs, because they are. So types of fluid therapy, there's no way I can give this talk, especially to this audience, without talking about like oral rehydration solution. And then we'll kind of swing more towards the rest of the lecture talking about IV fluid therapies. So oral rehydration solution, there's two basic types. So you have your glucose-based ORS and your cereal-based ORS. I think we're all quite familiar with these, and different packets look different, but this is the general idea here. And then, of course, your IV fluids consist of your crystalloids, and then we'll talk a little bit about colloids, although crystalloids are the main target here. So the glucose-based ORS, your indications it really is any case of like fluid loss in non-comatose patients. And your main reasons I think we mostly use it are diarrhea in children and infants, and then also in diarrhea and dehydration in the elderly can be quite beneficial. The WHO has very specific guidelines for the content of ORS, and that goes back to what are the components that you're losing based on which compartment is targeted. So that's how they came up with that, and that's why it's important to maintain just that combination. Contraindications of using ORS: if a child is comatose and they cannot swallow safely, that would be one contraindication. If they can't keep fluids down, you probably need to step up your thought process as to how to best resuscitate them and keep them from getting further dehydrated. So that's when we would move to IV therapies. The advantage of glucose-based ORS, it's quite effective, as we all know. We use it all the time. It's effective in treating and preventing dehydration, preventing shock in kids that are already dehydrated, improving vomiting. And then my favorite part is that it's not very expensive, super easy to use. You can teach families how to do this at home, very easily prepared. There's no need for sterilization or boiling or anything like that. And then the beauty is there's no real significant difference between IV and oral rehydration in study after study. So it's very effective. And then you have your cereal-based ORS. These contain like rice powder most frequently, or some type of starch that will serve as the glucose component. These are advantageous because they can be more effective in actually decreasing vomiting and in treating diarrhea. The cereal-based ORS has been shown to shorten illness duration and has been shown to be better specifically for cholera. The downside is it's not always that easy to find. It takes a little bit more to prepare it, unlike the glucose-based ORS. This you need to boil. It needs to be prepared fresh because after about 8 or 12 hours, it can ferment. And you have to have like specific enzymes to be able to process cereal-based ORS, and so not necessarily recommended for infants under 4 months. So IV fluid therapies, indications, I kind of lump these into 2 boxes, diarrhea and other. Diarrhea mostly because just that is what's most commonly used, especially when I'm working in Africa, and for you guys as well, just the most relevant indications. So diarrhea in regards to those with severe dehydration or diarrhea plus uncontrolled vomiting where they can't tolerate oral rehydration therapies. And then, of course, IV fluid therapies for kids that show up with traumas, shock, hemorrhagic shock especially, and then septic shock, various electrolyte disturbances. And then we'll do a lot of conversation about just maintenance fluid therapy. But just from a resuscitation and indications of IV fluids, this is when I go that route, when these cases are, or when these conditions are present. So when you take a step back, what makes an ideal IV fluid? Like, how do you know even which one to use? What are you looking for? So in general, like some of this seems pretty like common sense, but you're going to want a substance that has a high molecular weight. Now, why do you care about that? You care about that because you want the fluid to stay where you put it for as long as possible to try to increase the plasma volume. So when, for example, if you have a high molecular weight substance and you infuse it into the bloodstream, you want it to remain there long enough to do something, to improve your blood pressure or your perfusion, or to get forward flow so your organs can be perfused. So you're balancing your osmotic and your oncotic pressure in your circulatory system. And so you need something that has a relatively high molecular weight. Ideally, it's isotonic to that of plasma. And then this is the no-brainer part. You don't want anything that's like toxic or irritating or things that are going to interfere if you need to do cross-match for blood products. You want a fluid that's stable and it's cheap and easily available. So with this in mind, that is kind of how we have our specific, how our fluids have come to be and why we have what we have. This is a thought process in mind. So I think of fluids as like plasma expanders because that's what you're trying to accomplish. And the 2 main groups are crystalloids and colloids. And then of course, blood products are also there. Since this is a fluid therapy and not like a transfusion lecture, I'm not going to dive too deeply into your PRBCs, whole blood, FFP, platelets, but those are excellent from a resuscitation standpoint for some of the reasons we just talked about. They stay in the circulatory system where you want it. And the oncotic pressure keeps it there, so that's always a bonus. But those of course can be used, but we're going to focus on crystalloids and colloids. So what exactly is a crystalloid? It's a solution that contains electrolytes. We most commonly use isotonic fluids, and they are going to contain sodium as your like primary osmotic active agent. Now, when I think about the most common crystalloids, I instantly jump to like normal saline or lactated ringers, and those are specifically isotonic fluids, but we're going to talk about others such as like your half normal saline and such. So the advantage of crystalloids is they're easily available. They meet a lot of those criteria we were just talking about, from they're inexpensive, people don't have allergic reactions to saline, and they can quickly correct your fluid and electrolyte imbalances. And so your crystalloids are, especially your isotonic fluids, are the ones recommended for initial resuscitation. Now, there's disadvantages. So this, remember I was saying, like, we should think of fluids as like a drug or a prescription. So just like there's advantages to think about, there's disadvantages. So if you have large volumes of fluid that you're giving, you can increase the extracellular volume and you can cause like edema, peripheral or pulmonary edema. You can cause electrolyte disturbances, acid-base imbalances. And especially in little ones, if you're giving a lot of fluids, you can make babies cold if the fluids are cold, or sometimes even room temperature because neonates are so sensitive. But you can cause dilutional coagulopathies, and then, of course, the volume overload and have to deal with those side effects. So back to like the types of crystalloids, isotonic solutions are most common. So I'm thinking lactated ringers or ringers lactate, depending on where you are practicing and what you call it. And then normal saline or 0.9 saline fluids. Now, the benefits of isotonic fluids is your distribution stays almost entirely in your extracellular space. And so when you're giving this fluid, so essentially if you give a liter of normal saline, about 300 mLs is what is helping increase the plasma volume. So it doesn't all stay where you want it to, but it does help and does improve your circulation because some of it is going to stay there. So those are your indications, right? You're trying to improve your circulation, your blood pressure, your heart rate, your mental status, your perfusion in general, acid-base balance, trying to improve your urine output, all of these signs of fluid resuscitation and or fluid deficits. LR versus normal saline is a conversation that many people like to have, especially ICU docs. We love to debate this. In short, the WHO recommends either of these for rapid rehydration. There are pros and cons to both. Now, this is kind of more a little bit like my personal opinions and our like practice preferences here. But we know that the large amounts of normal saline can cause hyperchloremic metabolic acidosis. And that's been shown. I see this actually a lot when I'm in Malawi, just with like the Plan C rehydration plan and resuscitation. But so it's definitely something to keep in mind. And then because LR is a bit more balanced, so people are starting to swing a little bit more towards lactated ringers for resuscitation. But there are clear indications and contraindications, in my opinion, for both. So for example, if I have a child that has any sort of neurologic component to their presentation, whether it's a seizure, whether it's a head trauma, really any sort of potential neurologic condition, I will go for the normal saline because there's so much benefit in a normal or even high, sometimes sodium in kids with neurologic injury. So neurokid equals normal saline to me every single time. Same thing for renal failure patients. So we'll talk about in a second just the components, but lactated ringers has some potassium in it. So if I have a kid that I don't know if they're peeing or I'm worried about renal failure, they get normal saline, no question. LR I use a lot for just basic septic shock, or especially there's a lot of surgical literature about using LR. So if it's a surgery patient or a trauma patient, I'll resuscitate with LR. And then there is some pretty good evidence for pancreatitis. So if you're treating an older kid, especially with pancreatitis, LR is, there's evidence there. So in general, each has benefits. The world is shifting a bit towards LR. There was a study done that had 18 like healthy adults, and that's what's kind of shaping all of it. Because in that kid or adults with normal saline had more acidosis and more AKI and more coagulopathy, but it was 18 patients, and so that were healthy otherwise. So it's kind of hard to extrapolate that. But in general, we do see a little bit of a shift in a lot of people's practices of using LR. And then moving on to like hypotonic solutions. specific for pediatrics, I think about 0.45 normal saline or half normal saline and 0.2 or quarter normal saline. So these are great fluids to have in multiple different scenarios, especially if you're dealing with hypernatremia. And then infants, we will move towards like half normal saline, especially. All the recommendations used to be all children get half normal saline. This is going like by the wayside. No one is really following that anymore because we've learned a lot about kids in the hospital, especially just the differences in their risk for SIADH and other types of pathologies that make using half normal saline actually more dangerous and lowering the sodiums in addition to whatever is already going on. So the only time I ever use half normal saline is if a child is hypernatremic or if it is a small baby, like absolutely less than a month old, sometimes up to 2 months. But after that, I go normal saline actually, just to reduce the risk of hyponatremia. So from a fluid composition standpoint, I just kind of put the more common ones of what we use in pediatrics here, and then with the normal plasma for comparison. So you can see why people opt and lean towards lactated ringers because it's closer to normal plasma. However, the saline has advantages without the potassium, for example. And then you can look at the osms in comparison. So lactated ringers is technically almost isotonic, but we still call it isotonic anyways. And then there's hypertonic solutions. I'm just including this for completeness sake more than anything. So when I think about hypertonic solutions, I think about like 3% or 7% saline. Now, I don't have access to 3% hypertonic saline in the Congo, Malawi, or Zambia, so I'm not sure what you guys have access to, but we do use it a lot in the ICU here in Ohio. And so normally I think the general statement is that it's reserved for specialists and specialties, neurosurgery and ICUs specifically. And the benefit of hypertonic saline is the fluid distributes itself pretty evenly across the intracellular and extracellular space because of just the osmotic gradients. And so it definitely helps with some volume status, but the main reason we use it is to quickly correct sodium or to maintain a sodium in a child with cerebral salt wasting or SIADH. And mostly it's like in kids with brain tumors or meningitis or things like that. Because for sure, large volumes will cause hypernatremia. Like often that's why we're using it is to raise our sodium. But in like a seizing child that shows up into A&E with the sodium of 110 or 115, and you want to try to push up their sodium quickly, this is a great option to go to if it's available to you. But there's definitely regulations around it and a little bit of training needing to know like how much to give, what to watch for, and those type of things. It also, you can use it peripherally, but you need to make sure you have a good peripheral IV to give it. And then other types of crystalloids are your just dextrose fluids. So 5, 10, 25, 50%. And so your 5% dextrose, I think we use quite commonly and just as a source of water and nutrients. Your 5% dextrose or D5W should never, ever, ever be used for just like straight resuscitation. It's great for mixing in your fluids or mixing your IV medications or correcting hypoglycemia, but you should never use it solely for resuscitation. Like a kid comes in dehydrated and you give them a bolus of this, not the best idea. And then large volumes can actually cause water intoxication. And then of course, hyperglycemia just because of the dextrose content. And then this is honestly the only slide I put in here on colloids. So because we don't use them that much. The most common colloid that we use, so colloids are like plasma protein containing fluids. The most common colloid that we use is albumin, but there's other examples, dextran, gelatin, different starches. There have for sure been some very well done trials on the African continent using different types of colloids for resuscitation. And then there's been a ton of trials done using albumin for resuscitation and such all over the world. And at the end of the day, the recommendation is actually to use the isotonic fluids like we just talked about. There's a role for albumin for sure, but that should not be your first thought and your first go-to. All right, so when we think about components of fluid therapy, in my head, it makes sense to think about it almost in 3 different ways. I think about your maintenance therapy, which is just basically your fluid to keep things normal. You're not fixing anything, you're not replacing anything, you're just trying to keep everything as it is to compensate for your daily normal needs. Then there's the deficit therapy. Now, I think about this as your fluid boluses. When you come into the hospital, what are you behind? Like, how far are you behind? That's my deficit therapy. And then your ongoing and replacement therapy is the fluids to compensate for those ongoing losses. So, like I just said briefly, but the maintenance therapy, your goals are preventing things, preventing dehydration, preventing electrolyte imbalances, preventing protein degradation in ketotic state. So it's trying to keep you where you should be without preventing other badness while you're already sick. So maintenance fluid is calculated in pediatrics according to body weight. So I'm also an adult physician as well, internal medicine. And so it's much easier in the adult world because almost everybody just gets 100 mLs an hour and you're done. And if they have heart failure, you might give them a little bit less. And if they have something going on, you might give them a little more, but you can be rest assured you're probably going to give 75 or 100 and you're done. But in kids, that's not the case. And so using like the adult normals and such, we kind of hit our maximum for kids at 100 mLs an hour. There are rare circumstances, especially in big teenagers or some specific event, often when our surgery colleagues are involved, that you would give more than 100 an hour, but that's very short-lived. And then, so that equals a maximum of 2.4 liters a day. All right, so time for a little bit of math, as I was saying. So if you have your pen and paper, we're just going to talk a little bit about maintenance fluids calculations. So there's 2 ways to think about this and 2 ways to do it. You can either just calculate the estimated hourly rate and that's it, or you can calculate your daily rate divided by 24 and get your hourly maintenance rate. People learn different ways. I just go for the hourly. Again, this probably goes back to being an ICU doctor where I like things done fast. And so I don't want to take an extra step. So I just do what's the quickest for me. But the Holiday-Seeger rule or the 4-2-1 rule, these are what I'm talking about. So just as a quick review, from an hourly standpoint, we're talking about you get 4 mLs per kg per hour for kids that are less than 10 kilos or for your first 10 kilos. So for example, I have a 7-kilo child, so they get 7 times 4, they get 28 mLs an hour, done. And that's how you do it. If they are 16 kilos, now you've got your first 10 kilos, you get 4 per kilo, so that's 40. So now you still have another 6 kilos you have to account for. So we're going to do 6 kilos times 2 per kilo, because now you're in that second line. And so 2 per kilo, so you have 12. So 40 plus 12, you have 52 mLs an hour, and there's your fluid rate and so forth. If you want to do it from a daily standpoint, you take that same 7-kilo child, 7 times 100, 7 times 100, and then you're going to divide 700 by 24. And I'm going to guess you're going to get roughly the same thing that we got, because that's how this is created. So anyways, these are your 2 options of whether you're going to do hourly or daily. And so I have the same little chart on the next page if you need some reminders. But what I want everybody to do is just to practice for a second. So let's say you have an 8-kilo 1-year-old, a 12-kilo 2-year-old, and a 34 kg 9-year-old. So go ahead and calculate the hourly maintenance fluid rate for each of those children. Perfect. And somebody's putting in the chat, that's fine too. I didn't even say which way to go, but exactly. So for that first 8-kilo child, so back to the 8 times 4, so you have 32 mLs an hour for the 8-kilo kid. And then if you do the daily calculations and divide it by 24, I think you'll get 33 mLs an hour. So pretty roughly the same. And that's why either of them work. And then the second child, and if you haven't finished, that's fine. You can just write the answers and see if you can get to it later. But the 12-kilo child is going to be 44 mLs an hour. So you get 4 times the first 10 kilos, 40 mLs, and then 2 times 2 will be 4, so 44 mLs an hour. And then if you do the daily rate, it'll be 45 or 46. And then for the 34-kilo kiddo, you will run at 74 mLs an hour. So 32, 44, and 74 are your answers for those 3 questions. All right, and we'll just keep going. So when you are thinking, sorry, I might have skipped a slide. Yep. When you are thinking about your electrolyte maintenance aspect of this, so we talked about as you lose fluids, you're likely losing electrolytes too. And then daily, as you have insensible losses, that also includes electrolytes. So sodium, potassium, and chloride, just based on that intracellular, extracellular space, these electrolytes are often given in maintenance fluids and then also for replacements. Now, the sodium requirements for daily needs in a child, roughly estimated for kind of all ages, is between 2 to 3 milliequivalents per kg per day. And then potassium is a bit less, 1 to 2 per kg per day. The chloride that you need can be accounted for because most of the time, as long as you're using either sodium chloride or potassium chloride to replace these, you'll meet your chloride content and chloride needs. So there's no need to do, we don't often do specific calculations for chloride, assuming at least one or both of these are going to be given with chloride salts. And then glucose would be the other aspect of maintenance electrolytes to think about. Most of the time, we reach for 5% dextrose in our maintenance fluids in kids. So you have your D5LR or your normal saline with 5% dextrose. And so there's a little under 20 calories or 17 calories for every 100 mLs of fluid when you give 5% dextrose. This meets about 20% of the daily caloric needs, so it's by no means like replacing all nutrition. Back to remember just the maintenance. You're trying to prevent stuff. You're preventing the ketone production and trying to decrease your protein degradation. But kids on this will still lose weight because it's like a diet. You're not meeting all of their needs, but you're just trying to keep things from happening, essentially. So we talked about maintenance therapy. Next would be the deficits. So earlier I mentioned when I think about deficits, I think about what are you coming in the door like behind and missing. So this is when you would give your fluid boluses. There's a lot of talk all around the world about the volume of fluid boluses that are needed, or if you even should give fluid boluses. Especially some of the work coming out of Africa is having that discussion. But currently, the overall general recommendations are fluid boluses when kids come in the door when they need restoration of their circulatory volume. Now, how much you do, that's still up for debate. And even amongst my colleagues, we all do this a little bit differently. But in general, depending on severity of hydration or illness, giving up to 60 per kg of isotonic fluids is pretty standard in high resource settings. I know the FEAST trial in Africa makes it where giving more than 30 or 40 per kg of fluid boluses up front in resuscitation actually had worse outcomes. So I think the safest thing to say is for me, my practice is I give up to 60 when I'm in my high resource settings because I have the ability to have easy access to diuretics or dialysis or a ventilator or CPAP machines and things like that. When I'm in Africa, based on the FEAST trials, I normally stop around 30 per kg unless there's a very solid reason to continue to give fluid boluses. So we give in 10 to 20 per kilo, and these should not contain potassium and shouldn't contain dextrose either. This is your normal saline or your lactated ringers done. And then if you're worried about a cardiac condition, giving them 5 to 10 per kilo boluses is very reasonable. And then, so that's like our deficit. And then as we're talking about our ongoing rehydration, it's like, all right, what are your fluid losses? What's going on? Is it because of diarrhea? Is it because of their vomiting? This is important because different fluid losses have different electrolyte contents. So the main takeaway from this is your diarrhea has sodium, potassium, and bicarb. That is very different than vomiting, which is sodium, potassium, and chloride. So think about this in your pyloric stenosis baby, right? Who is just vomiting all the chloride. So they actually are alkalotic because they have a buildup of the bicarb. Diarrhea content, diarrhea, you're having lots of stool losses. So they get acidotic because they're losing all their bicarb. So your fluid replacement should mimic or do the best you can to account for what's happening. So there are very specific calculations you can do where you need 55 milliequivalents of sodium and 15 of bicarb and 25 of potassium. So that's not always realistic. In reality, when you're replacing stool content, the recommendations are trying to figure out something that has all these components in it. So we personally use a lot of LR for diarrhea or stool replacements because of the bicarb content, and then use a lot of like half normal saline or saline for the vomiting component because of the chloride needs. So those would be my recommendations just in what you have access to. If you can have fancier fluids to be able to do 60 of sodium and 90 of chloride and 10 of potassium, go for it. But I think the easy thing to do and think about is using LR as stool replacements if you need to, and then using half normal or normal for your emesis when you're going to lose chloride. Renal replacements are always interesting. For kids with renal failure, which could be their own lecture, often we'll do just 1/3 maintenance fluids that covers their insensible losses, and then replacing their urine output. If they're anuric, then that's nothing. If they're polyuric, then this gets very, very important so they don't get dehydrated. And so we'll often use half normal saline in those situations as well. We would not use LR in a kid with renal failure because of the potassium. All right, and then our last topic is in our fluid replacement and therapy talk is talking about dehydration. So dehydration, we're thinking about just excessive loss of body water and you're losing more than you're taking in. So you're draining out more than's being filled into your bucket. And you can lose fluids from both your intravascular and your extravascular space. And depending on where you're losing it from, it kind of makes different effects. So intravascular loss is your hypovolemia, your serum osms go up. Extravascular, you actually have changes in cellular function and your tissue laxicity. So from a calculation standpoint, because we have to have a little bit more math for the rest of this, when you are calculating your percent of dehydration, or your percent weight loss, you are looking at your pre-illness weight minus your illness weight divided by your pre-illness weight times 100. Now, we often don't have the ability to know what kid weighed before they got sick. So this isn't always practical, which is why we'll talk about clinical signs of dehydration in a second, but this is the correct formula and it'll come up here in a second again. And then your pre-illness, or sorry, and then your estimated fluid deficit, you're looking at your pre-illness weight times the percent weight loss that you just calculated and multiply that by 10. And that is your fluid deficit. So here it is practically, if you want to grab your pen again. So you have a 4-year-old that is presenting with vomiting and diarrhea. They were 17 kilos before this illness. You conveniently know that. And today they're 15.5 kilos. So you're going to calculate their percent weight loss and your estimated fluid deficit. And I put those calculations down at the bottom just to help you out a little bit. So if you want to look at that quickly. Great. Someone's putting 8%. So you're looking at your pre-illness weight of 17 minus your illness weight of 15.5 divided by 17 times 100. And then your estimated fluid deficit is your pre-illness weight, or 17 times the percent weight loss that you just got, which I think I had like on this child, maybe 8.8 or 9 or something, times 10. Now, the other thing and quick and easy way to look at this is 1.5 kilos is normally equal to about 1.5 liters. And that's roughly what you'll get here as well. So that is just kind of, when I eyeball it, I'm thinking it's going to be something close to that. All right, and then I think we should all be familiar with this chart, but this is more a reminder that it exists, of looking at because I know for me, we look a lot at like the WHO, severe dehydration, some dehydration, no dehydration. And here's another version of that when you're just looking at the percent weight loss. And when it's not just diarrhea, this is important to know. And I think just briefly, when a child is mildly dehydrated, they could be down 3 to 5% of their body weight. The clinical findings often overestimate dehydration, but that's just kind of how it is. But do know that you're more likely to overestimate if you're using clinical criteria like this. But a mild dehydration is the most interesting thing that you might find is the child might be thirsty and they might have a little bit decreased urine output. Everything else is pretty normal. When they're moderately dehydrated, that's when you see the tachycardia, the irritability. They might have a little bit decreased pulses, sunken eyes, little decreased tears, and their urine output might fall below 1 per kg per hour. It's the severe dehydration when these kids are altered. They're tachycardic. They could have decreased or thready pulses. Cap refill is markedly prolonged. You could have abnormal respiratory patterns, kids have acidosis or something, very sunken eyes without tears, and then poor urine output, if any. The ranges of dehydration, you can kind of see up here at the top where it's like an infant versus a young child. People might just say, okay, mild is 5%, moderate 10%, severe 15%. And then an older kid or adolescent, it's like 3, 6, 9. So that's just like a quick and easy way to think about it, that we use a lot. If you're estimating your dehydration, 5, 10, 15 for a little kid, 3, 6, 9 for an older kid, as you're trying to calculate your percent dehydration and weight loss. But that works a lot of the times. But I mean, it's obviously not the most perfect thing ever, but it is one way to think about it. So when you're approaching dehydration, you need to think about the initial resuscitation or stabilization. Then you're thinking about, okay, what's your percent dehydration? What type of dehydration do you have? What should I use to fix it? I think this chart is gorgeous. I just showed you the other half of it on the other page, but the thing that I want to, there's some review things that we've already talked about, but what I want to bring up is under the severe dehydration part where it's talking about calculating IV fluids. And we're going to get to this in a minute, but just go ahead and put it in your brain that when the kid rolls in and you're doing the initial resuscitation in A&E, that you're giving 10 to 20 per kilo, or 5 to 10 per kilo if you're worried about the heart, like I said earlier. And then you're going to calculate your fluid deficit, like we talked about earlier. And then you're calculating your maintenance fluids, and your total replacement, it's going to be your deficit plus your maintenance. And then you actually subtract what they've already gotten from the bolus. And so this talks about dividing your volume over 24 hours and running that rate. And we'll talk about some other ways to do it as well, but this is a perfectly acceptable way to do it. And then of course, increasing more if you have ongoing losses. And then again, at the bottom, you'll see typically D5 normal with 20 of K. So that's covering all of your electrolyte components that you may need. And then just a reminder, as the WHO has their own standard, especially in kids with diarrhea in regards to the level of dehydration, and then your plans for it that we all know very well as Plan A, Plan B, and Plan C. So this is more of a reminder. This is kind of the standard of what we're doing, especially in our African countries and with our kids in lower resource settings. So just a reminder, these are here. I'm not going into this because I think you guys will be more familiar with this than maybe some other components of this lecture. So we'll just keep going. So I said earlier, we need to figure out like the type of dehydration. And this is the last part of this lecture of, okay, what does that mean? So the terms isotonic, hypotonic, and hypertonic are often used to describe types of dehydration as well as fluids like we did earlier. We will also use these. If I use it interchangeably, don't let me confuse you, because sometimes it's referred to as isonatremic, hyponatremic, and hypernatremic dehydration. Again, because your sodium is your most likely electrolyte to be affected in dehydration. So in isotonic dehydration, like this is your most common causes of, or most common type of dehydration. These are the kids that roll in with decreased PO intake, vomiting, or diarrhea. And then they have a normal-ish sodium, or often quite normal. Their osms look pretty good, and their water to sodium loss is equal. Versus your hypotonic or hyponatremic, you've got low sodium, low osms. You're losing more sodium than you are water. These are the kids that have been vomiting and then they're just drinking a lot of water. So they are losing sodium, but they're still getting free water in, so they become hyponatremic. This can happen if we choose the wrong fluids to replace it. This can also actually happen in hyperglycemia. It's a little bit complicated there, but it can. And then renal dysfunction. And then hypertonic or hypernatremic, you have too much sodium, your osms are high, you're losing way more water than you are sodium. This is like you're vomiting, burns, fevers, diabetes insipidus, where you just cannot keep up with how much they're peeing. Maybe you're not replacing their water enough from a fluid resuscitation, or diuresing them too much. Of course, if you just have way too much salt in your body, that also happens too. If you're giving sodium supplements and then you give too much. So in isotonic dehydration, you're giving maintenance fluids plus the replacement of your deficits. And typically we'll do that with normal saline or LR in this case. But since your sodium's normal, it doesn't really matter which fluid you use. So from a water deficit standpoint, you're taking your percent dehydration and you're multiplying it by your body weight. So half of the deficit is replaced over the first 8 hours, and then the remaining half is over the next 16. So remember, the child with isotonic dehydration has lost equal contents essentially of water and sodium, and probably potassium as well. So we see this the most. Normal sodiums, you don't have to correct anything too slowly. There's not really any shifts between fluid compartments. So you're just calculating their deficit by their percent dehydration times their body weight. Hyponatremic dehydration. Now, these kids need both water and sodium. So it's important to calculate both. However, typically when you're replacing their water deficit, you're giving them something with normal saline because they're hyponatremic, and that's going to replace their sodium needs too. So in general, you're calculating their water deficit and their sodium needs and making sure you're meeting that. So you're going to give, again, half of that deficit over the first 8 hours and the remaining half over the next 16. This helps you correct in about 24. And then plus your maintenance fluids. Now, sodium needs. So desired sodium. I like things to be perfect, so I always like shoot for a sodium of 140. That's not always the recommendation. So a desired sodium can be 130, 135, like the low end of normal. But typically in a lot of these calculations, you'll see 130 as your desired, just to get you closer to physiologic minus your current. Now, if a child is seething and their sodium is less than 120, you're going to try, your desired at that moment is going to be to get them to 120. Okay, so not seizing 130 is your desired, seizing 120, and then you can slowly increase from there. So your sodium correction should never ever exceed more than 8 to 12 milliequivalents per liter per day. So 8 to 12. Some people say 8 to 10, some say 10 to 12. In general, you just don't want to do more than half a milliequivalent per hour. So that equals about 12 in a day. The reason we care about this is if you do it too fast, you can get osmotic demyelination syndrome, or another word for this is central pontine myelinitis. That's headache, confusion, altered mental status, and you can actually have respiratory arrest from it. And then, of course, you can always consider using oral supplementation of sodium if the child, especially if they have a nasogastric tube and will take it. And then remember, your saline has 154 milliequivalents of sodium. Half normal would have 77, but you probably aren't going to use half normal when you already have a hyponatremic person. So we have this calculation, and then we have one for hypernatremic, and then that's it. So from a hyponatremic standpoint, I want you to practice calculating both the fluid well, just kidding, I already have the answers. We'll talk through it. Calculate the fluid deficit and the sodium deficit for a kid that's 12 kilos, severely dehydrated, and has a sodium of 110. So your fluid deficit is your percent dehydration, so 0.10. So we're going to say that kid is 10% dehydrated. And then the times 12 kilos. And so you're going to have 1.2 liters as your fluid deficit. Then your sodium needs, you've got your desired of 130 minus your current of 110 times 0.6, because that's your percentage of like total body water, times 12, which is your weight. And that's going to give you 144 milliequivalents that the kid needs. Now, if you are replacing 1.2 liters and you're using normal saline, that's what, 154 milliequivalents plus more. So you're going to meet your sodium needs in that. All right. And so remember, you're giving half the fluid deficit over the first 8 hours, and then the other half over the next 16 hours, plus your maintenance fluids on top of that. If they've already gotten resuscitated with any fluid boluses, you'll deduct it from your fluid deficit. And then lastly, your hypernatremic dehydration. So for this, you estimate your free water deficit, because remember, we're expecting you've lost more water than you have sodium. The calculation for, there's actually several, but the one that I like the best and is used most often is 0.6, again, your total body water, times your weight in kilos. And then you're going to have your current sodium divided by 145, or your goal sodium, minus 1. And then for this, it's a little bit different. The recommendations are often to replace half the deficit, again, minus the boluses, over 24 hours and do it a bit slower. And then the second half is over the next 24 to 36 hours. We want to do this slowly because rapid correction causes cerebral edema, and that is, kids are pretty at risk for that. So again, you're looking for your change in sodium to be about half a milliequivalent per hour. And then this is just a kind of walkthrough of what we just talked about. You have an 18-kilo girl, moderately dehydrated, sodium of 164. She got a bolus in A&E. What's her free water deficit, and what is your fluid rate going to be? So your free water deficit, you've got 0.6 times her weight of 18 kilos. Then she has a sodium of 164. You're trying to get to 145. So 164 divided by 145 minus 1. And sorry, that should have a bracket there. So then you're going to multiply that by 18 and then by 0.6. You get 1.4 liters as her fluid deficit, or her free water deficit. And so 1,400 mLs minus the bolus of 20 per kg that she got in the ED or in A&E. So 1,400 mLs minus 360 leaves you with a little over a liter that needs to be replaced. So you're going to replace half of that over the first 24 hours. So that gives you 22 mLs an hour. And then you also need to add your maintenance fluids per hour. So that child will get 78 mLs an hour of fluids. So I did that quickly, but I just wanted to walk through at least one example with real numbers. So I think the takeaways for this and then summary, remember fluids are like a prescription. Give them with caution. Children are much more vulnerable to fluid losses, so that is one big difference in pediatrics. Calculations are weight-based. It doesn't really matter their age or their gender, they're weight-based. And then if you're in a hospital system, monitor their weight and their urine output as an indicator of how you're doing from a fluid resuscitation standpoint. And it is important to monitor their sodium as you can. Now, even in high resource settings where like we could check a sodium every hour in our ICU if we wanted to, even with that, we still often too quickly correct sodium, or it doesn't go as fast as we think. So it is not, every child is different. And even with hourly sodiums, it's not always perfect, but these have just been a review of the evidence-based ways of doing it. Try to give oral replacements when possible. There's just less side effects. And then always use LR or normal saline for your resuscitation. And that is it. And I will take any questions, or you guys can email me as well, and I'll be open to that.
Thank you so much. That is always a good review. I've been doing medicine for probably almost 30 years now, and I still need to pull out my calculator. Maybe it's just the pediatrician in me. I do think sometimes it's easier in the adult world, but it's always an important review, especially when we see some of these really sick kids. As you mentioned, dehydration is just one of the more common things we see in an emergency or urgent care type presentation. Please feel free to ask any questions or comments or suggestions or anything related to even critical care. Since Dr. Weinkoop has such an extensive experience, we love to collaborate. And if you don't have time or the ability to do that now, you can email us and we can circle back with you. We really appreciate all your time. You know, you're busy. Are you currently in the US or are you in sub-Saharan Africa?
Yeah, I'm currently in the US actually. So here for a couple months.
Okay, that's good. Right.
I think Elizabeth might just have one question.
Yes, please either type it in. We have time if you need to type it in. I can read it out if you're not able to unmute. I'm not sure if everybody is muted. But yeah, or if you have a case that you want to go over, that's always helpful. I find examples very helpful. But please type in your question.
Like a materials or reference. Yeah, no, I actually have like a handout, Traci, that I can give with some of like the summary of this. And then also it has on there like including like different drip rates and such, since we often don't have the ability to have like what am I looking for from a fluid standpoint, and we're just counting drips from an ml to figure out what's getting. So there's some of that is included, and then some more specific like starting with smaller fluid bolsas because of being in high malaria areas and such. So the handout kind of goes through some of those things. I don't mind sharing. I don't know how I can give it to you and we can distribute or whatever's best.
Yeah. So are you, and yes, and I think you were referring like using if you're doing like a hand drip or like if you don't have a pump or something. Yeah.
Yep.
Yeah. I love cheat sheets, as I call them. Like I said, I've been doing medicine for almost 30 years, but I still love to have like pocket guides or like a simple sheet to hang up in a clinic. Yep. Or a code room even. Sometimes we all need to just go back and look, especially if you don't normally see kids, or if you see kids and adults and need to change gears back to kids and you're not used to doing all that weight-based calculations. It's very helpful. Yeah, if you have like a one pager, I can get that distributed through our Go High partners, get it out to the pediatricians and the other lead clinicians at
Yeah,
our host sites, and then they can
sure.
distribute it. And for my trainees and for those I work with in Uganda, I'm if you have that, I can even try to make it and laminate it, so that people can carry it in their pocket, so to speak. So yeah, you can email that to me, and I'd be
Sure.
happy to
I don't mind.
disseminate. Or if you have like another pocket, I mean, I know I still use things called the Harriet Lane. I don't know if
Oh
people
yeah.
still use that.
I use this all the time. I don't know if it'll
Yeah,
show up,
uh,
but my WHO book.
I love
Um,
that. Yeah, is that the one for like
Hospital
hospital-based
care.
care? Yep, use that all the time. Like I said, still go
It
back to it after decades.
looks like the question was about management of dehydration in neonates and kids with underlying cardiac illness, and then experience regarding that. So cardiac illness is, so the things that are different about cardiac illness, and then the same is true with like severe acute malnutrition. How you resuscitate in the setting of dehydration can definitely be different, and then what you reach towards fluid wise. So personally, if it's a cardiac kid, I will do 10 per kilo fluid boluses, or 5 per kilo fluid boluses up front. And then I'm just using their liver, if it drops or not, to determine how much to give. But I would not go over 30 per kilo in a cardiac kid up front. And then what I often do is give 10 per kilo and then look for, could they tolerate blood products, or would they benefit from blood products or something like that, that would stay in the intravascular space a little bit better. So that's kind of if I can find a way to find something else that might be beneficial to them, I'll often try to do that as well as part of the resuscitation and move a little faster to blood than I may in other cases. So that's just me. That's not a lot of evidence, but that's kind of my experience and what I would do.
Yeah, I agree to go slow with the kids with severe acute malnutrition. But that's a general rule of thumb. Kind of treat them similarly as basically a risk for heart failure with fluid overload. Sure.
And
Yeah.
then often, yeah, and especially in like a lot of times people aren't even giving fluid boluses up front, and like the severely anemic kids that are coming in, right, to have a hemoglobin of 3 or 4, maybe start maintenance at most, but doing blood first before giving fluid, just because of the dilutional content. But yeah, no, that's a great question. And I'll try to get that. I'll try to make the handout into one page. That'll be way better. And then shoot it to you, Traci. I start in the ICU tomorrow, so it might not be before that, but I'll let you know.
Oh, no worries. We'll always circle back. And like I said, it's ongoing discussions. And
Yeah, for sure.
we work all year, even when the Summer Institute officially ends. We're always planning for the next years and also giving feedback to both the providers and the participants. And
Great.
so, yeah, that's very helpful. Any other last minute questions or comments before we end this session?
No, thanks for the invitation. I appreciate it.
Yeah, no, thank you for your time. We really, really appreciate this. This is like a great forum, but we recognize, everybody's busy. So
Yeah.
we love it. Thank you.
Thank you.
All right. Do our hosts have any other comments they want to make for this morning's session coming to an end, or this afternoon for you? Sorry, it's morning over here in Ohio. Well, like I said, if you do think of things after the lectures have ended, yes, please do complete the evaluations and the surveys. The link is in the chat box, so we can get that to you afterwards if you missed it, because we do like to get feedback on what we're doing and what we can plan for the future. And we will be having, obviously, there's more days of the Summer Institute. Our next day of pediatric specific lectures will be on August 19th at the same times. There'll be 3 lecturers at the same times. I really appreciate everyone's time. I know you're very busy. This is probably your clinical afternoon, and so I know it's hard to sometimes get away from patient care, and we do appreciate your joining us. Thank you. Well, I hope everybody has a great day. I think that went well. If anybody has any feedback, feel free to send me an email.